Pablo?
Vladimir, you got it?
Yeah, I got it. I deleted your message from day before, you know, so I didn't have the address.
No worries. I hope everyone has I think automatically 1 hour before the event, you should have all received the new link. But
so anyway. I shouldn't worry.
I will have to leave in 10 minutes, but I'm with the phone. So whatever you need, just let me know.
I hope I will need nothing.
I don't know, maybe some audio problems as yesterday.
Yeah, yesterday there were.
Ramesh,
hello. Kazadi, did you
hey, how are you?
Get my mail, Kazadi?
How are you?
Yeah, we have discussed this with Imad, and we cannot move your lecture since we would interrupt the flow of the course. So we cannot move you forward. So let's skip your lecture for today and let's keep it for the next spinal meeting. Is it okay with you?
Okay, that's fine. Okay.
Okay. Because the flow of the topics would be interrupted, and it's going from tumors down to degenerative.
Vladimir.
Yes, sir.
I want to ask, should I follow Victor's vascular anatomy with the vascular lesion, or I mean, it's just up to you. I don't mind, but just asking.
No. The program is as it is, with no changes.
Okay, that's fine.
Okay, fine by you?
Yeah, fine by me. Yeah.
Very good.
Okay, no problem then. Okay, I will then keep it for next.
Kazadi, okay by you? We shall have your lecture in the next course when we have the spine problematics. Miguel, are you there?
Okay.
I think he's joining. Okay. Miguel is joining.
Miguel and Roy, they have connected, but probably they are in that step in which they have to click join with computer audio. That's why.
Probably. Yeah. Probably.
Pablo, are you here today throughout, or are you?
Well, I will leave it open. You are co-host indeed already, so please give me a hand because I need to go to the clinic and then to the university, but I will be with my phone. So if there is anything, you let me know because I'm already recording on YouTube.
Okay.
Everything is fixed. I hope no audio problems as yesterday, but you know
I guess the problems were because Jose was moving his hands, so that I didn't say that.
Yeah. You didn't want to stop him.
No.
Well, the thing is that in some hospitals also the Wi-Fi net is really powerful, as in some moments many people are using it, so the length it's very small at that time, so it cannot afford audio, video, and screen at the same time.
Maybe.
I had that problem with the Indians, and we solved it just disconnecting my camera. So they couldn't see my face, which is very nice not to see it.
Of course.
They could see the screen and listening to me. So that
was a nice bonus for the participants.
Say again?
That was a nice bonus for the participants.
Yes. How is everything, Vladimir, Ramesh, Kasadi?
Yeah. Well.
Everything okay?
Yeah, fine so far. Is that a Roy behind? Roy, you're always right.
Yourself.
Well.
Excellent.
How are you?
Yeah, not too bad.
Well, you will run first.
I'm trying to say hello to everyone, and then I will be off.
So,
okay.
What is the final distribution for moderation? Because at 4 GMC, that is to say 6 European Central Time, I have to rush. So maybe we are not going to finish on time. My suggestion was Vladimir, you first, because you have to leave at 5, right?
Yeah. Well, first 3 lectures are up to you, okay? Then I will take over for the next 3, and I must leave them. So Matthias will finish the course. Okay?
So the last 3 for
the first three are up to you. You are chairing the first 3 lectures.
Good. So second, who is going to be second?
Second, I guess I don't have the program with me now. Wait a minute. Let's find the program.
It's in our group, Vladimir. It should be in our group.
Yes. Yes.
Hi, Miguel. How are you?
Hello, how are you?
So I think after the first three is Atul Goyal and Salman and Miguel.
Yeah. How are you? Everything okay? Oh. Hello.
Hi, Victor.
Can you hear me?
Yes, yes.
Yes, of
Can you
course.
hear me?
Yeah, we can.
We can see you.
Okay.
We can hear you.
Thank you. Thank you.
Some of them fine, some others they are sick.
Oops.
And they are okay. But the thing is that we have a huge waiting list, and the manager gave us extra ORs.
Oh, but no people to do it.
No people to do it, and public here to do it.
Right. Yeah, good.
They need it now, yeah.
Miguel?
Yes.
Yeah. The first three lectures is anatomy by Victor. Then I'm going to talk on spinal cord tumors and Ramesh on spinal vascular lesions. Then we are going to developmental, and I will do it. It's Skyre by Atul. Then anatomy of disc surgery, Salman, and posterior approach by yourself. Okay.
Right.
And then we have the last three. I don't have it now. Matthias will do it because he's sharing with us. Fine by you?
So Vladimir, who is going to moderate the last three sessions?
Matthias Baldoncini.
Right. Perfect. So insofar as you make the introduction, I will just start the moderation. How long every presentation? 15 minutes?
20 each lecture plus 5 of discussion.
So,
okay.
So finally, sorry, how long? Excuse me, Vladimir?
20 minutes lecture and 5
Right.
minutes discussion. Keep it below 25 minutes altogether.
That's okay.
And everyone who is giving the lecture is asked to reply to all those questions which are in the chat or Q&A below on the bottom of the screen.
Perfect.
Perfect.
Hello.
Hi, Igor.
Hi,
Roy.
Igor.
No news. What's happening?
What?
I'm asking Roy because he's.
Hey, hi, Ramesh. Hi. It's been busy here, Ramesh.
Yeah, I can understand.
Hey, Igor.
One second, I have Pablo on the telephone.
I know, I had Pablo just now, it's the same thing, yeah. Hey, just wanted to introduce Simo. Look at this guy. Hey.
Hello, Igor.
Igor, this is Simo. He's going to be joining you next month.
Nice to meet you. Nice to see you guys.
Igor, how are you doing? I haven't seen you for long.
Yeah, I was there yesterday.
You are busy?
Yeah, it's nice. It's okay.
Good.
How is you were telling us the you have probably a second wave in Czech Republic?
We do. We have like 3,000 new cases a day, which is in 10 million country. Rather a lot.
Okay.
Rather a lot. But the healthcare is still coping, but barely. Just on Monday are starting again the dictatorship.
Dictatorship. Yeah.
For 2 weeks. You cannot call it any other way.
Vladimir, Imad is not joining us today, or?
He is at surgery, so he will join us as soon as possible. But I believe that I
We
shall
should
start.
Yeah.
In a minute.
Yeah.
We have still 1 minute time. And
Yeah.
I will hand over to Miguel.
Okay.
Miguel, do you have a program in front of you?
Yes, I do.
Good.
So
why don't we start?
Yeah.
Agreed? All the faculty?
Yes.
Hello everyone. Welcome at the second day of the WFNS Neuroanatomy Committee course. Today will be dedicated to spine and all the problematics in the spine. And of course, we shall keep something for the next course. Let's start, and I shall hand over to Professor Araez, who will share the first 3 lectures. Miguel, please.
Thank you very much, my dear friend Vladimir. First of all, thank you very much for the opportunity to take part of this wonderful webinar as a lecturer and also moderating. And it's a great pleasure for me just to invite Dr. Victor Hugo Perez from Mexico to start his talk on vascular anatomy of the spinal cord, with a special mention to the great posterior neuromedullary artery. Okay.
Thank you very much.
You can share your screen.
I think I cannot share the screen. Sign that.
No, I changed it now, Victor. I think you should be able to do it now. Try again.
Okay.
You are supposed to have something green.
I think initially the option was only for host, so I changed it.
At the bottom.
Okay. Okay, can you see it?
Yes. Can put it on the slideshow, Victor.
Can you see the screen?
Yes, but enlarge it.
You can put it on the slideshow, Victor, and then.
That's it.
Yeah.
Is okay?
That's fine.
Yes, fine.
Okay. Okay. Thank you. Okay. Let's talk about the vascular. As you know, Albert Adamkiewicz first artery. He drew some features and also the anterior great radiculomedullary artery in the spinal cord. These are some of his drawings, and nowadays we can make a better job because of it's very easy to get silicone, red silicone for arteries and the color blue for veins. Adamkiewicz injected arteries and veins of the spinal cord, applying some special substance. Now I am using silicone, and we can get very nice, very beautiful pictures. Here we have the anterior spinal artery coming from both vertebrae. Spinal cords were extracted via posterior incision from the occiput to the sacrum. Anatomic dissection was performed until reaching the vertebral line. Laminectomies were performed from C1 to were cut with care so as not to lesion the dura. As you can see in this picture, here we have the dura mater with the spinal cord. Red natural latex was injected into the Adamkiewicz artery under moderate pressure and closure to avoid contrast extravasation. The injection was continued until latex filled distal small caliber arterial vessels, posterior spinal arteries. Veins were injected with blue natural latex. Here we have an injection of this technique. We can reach very small arteries, maybe arteries about 50 micras or less. The great anterior radiculomedullary artery is located in the anterior aspect of the spinal cord, where it took a characteristic hairpin. Realization of this artery is very important in the surgical transthoracic spine procedures. Here we have the Adamkiewicz artery. This is the aspect of this beautiful artery. Here we have a left, this is the right side origin of this artery. A left-sided vessel was present in 45 specimens, and a right Adamkiewicz artery was present in only 5 specimens from 50 spinal cords studied. This is another aspect of this Adamkiewicz artery. This artery is coming from T9 in the this is the most common origin of this artery. And this runs along to the anterior aspect of the spinal cord to reach the conus medullaris. Where it reached the conus medullaris is giving 3 arteries. One of them very small, it is going for the filum terminali. And those 2 arteries are going to the posterior aspect of the spinal cord. This is known as posterior medullary artery. Although variability exists to the overall caliber of radiculomedullary arteries, dominant radiculomedullary arteries are present. The most important radiculomedullary artery is the arteria radicularis magna, otherwise known as the artery of Adamkiewicz. The Adamkiewicz artery arises in the thoracolumbar region between T8 and 75, a diameter of almost 1 millimeter. This is another picture in the lateral aspect of the spinal cord. Here we have the conus medullaris, and this is a small branch of this Adamkiewicz artery. Here we have a thoracic artery, and this is the great anterior spinal artery. You can look the difference between the size of this thoracic artery and this anterior artery. The preoperative localization of these arteries in procedures, the anatomical knowledge gained preoperatively may reduce the risk of postoperative paraplegia. Here we have the highest level of the origin of this artery. This is coming from T3. In this picture, we have the cervical segment and thoracic segment of the spinal cord. And this is the T3 level. And here we have the thoracic segment, and here the lumbosacral segment of this artery. As you can see, this artery has a very long direction in the anterior aspect of this spinal cord. Here we have a close view of this artery. The lowest level in 2 specimens was in L2, in the second lumbar root nerve. This is the second lumbar root nerve. And here we have the origin of the lowest level of this Adamkiewicz artery. If we separate these root nerves in the cauda equina, we can see the lateral aspect, the lowest level of the origin of this Adamkiewicz artery. Here we have the anterior aspect and posterior aspect, and here we can see the anastomosis of this posterior and anterior arteries. Of this Adamkiewicz artery, the most was in T9. This is a spinal cord with three arteries of Adamkiewicz, one in the left side and two in the right side. A close view of this feature. Understanding the basic vascular anatomy of the spinal cord is of utmost importance for imaging interpretation and endovascular and surgical management of spinal cord vascular malformations. Advances in diagnostic and therapeutic interventions have led to a need for more detailed and specific understanding of the microvasculature of the spinal cord. In particular, attention to the anatomic variation of the smaller caliber circulatory supply to the spinal cord allows tailored management of specific patients. Here we have the posterior aspect of this spinal cord, and here we can see very small arteries in the posterior aspect. The existence of a great posterior radiculomedullary artery has attracted little attention and has been a matter of debate. Various authors postulate such a vessel, do not mention it or even deny its existence. This discussion was about the 60s, in 1962, 1961, but nowadays very few is investigating this beautiful artery. According to Jellinger, a large portion posterior radicular artery is in caudally in about 75% of instances, but its caliber does not approach that of the large anterior vessels, diameters 3.5 and 500 microns. Its site is more caudal than that of the anterior radicularis magna arteries. Now, here we have the great posterior radiculomedullary artery. There is no doubt about its existence.
This is a great posterior radiculomedullary artery. It is coming along to the 12th thoracic nerve root in the right side. This artery makes a curve.
Victor, you are not well heard. Try to speak.
Excuse me?
I think it's a video. It's a video, Vladimir, I think.
I know, but you should comment on it.
Okay. Can you hear me?
Yes, it's okay.
Okay. The artery of Adamkiewicz in the spinal cord specimens, a number of 50 spinal cord studied, was injected with colored latex until the small caliber arterial vessels were filled and the great posterior radiculomedullary artery was identified. The course, diameter, and location of great posterior radiculomedullary artery were documented. Here we have another picture in which we can see the conus medullaris, this vein, and also these arteries and the cauda. Here we have another video in which we have a connection. The Adamkiewicz artery, and this is the great posterior radiculum running along to the lateral aspect of this spinal cord. Here we can see this, and if you look in this video, we can see these nerve roots, and the artery in this case is very, very small. And there is no connection between this posterior aspect of the spinal cord with the Adamkiewicz artery. In this case, the irrigation of this side of this spinal cord is great posterior radiculomedullary artery. In this spinal cord, there was not a great posterior radiculomedullary artery. Instead, there were several radicular arteries, as you can see here. A variable number of radicular arteries originating from segmental arteries or homologous vessels make arterial contribution as lateral feeders along the course of the spine. These radicular arteries are small but differing calibers. Most of these radicular arteries supply nerve roots, the dura, or the pial plexus. Only a few of these radicular provide the arterial supply to the collateral network of vessels supplying the spinal cord. These vessels are specifically radiculomedullary arteries. This is an injection and also a beautiful picture about these small radiculomedullary arteries coming along to the nerve roots. A great posterior radicular artery was identified in 72% of spinal cord specimens. This total included specimens in which unilateral or bilateral great posterior radicular arteries were found, as well as a single case in which 3 great posterior radicular arteries were evident. In 26% of the specimens, unilateral left-sided was present. Lateral right-sided was present in 22% of specimens. In 22% of the specimens, bilateral great posterior radicular arteries were present. As you can see in here, this is posterior aspect, this is the right side. One specimen demonstrated 3 right-sided great posterior radiculomedullary arteries in this case. The distribution of this artery based on side and spinal level. As you can see, these arteries coming, most of them are in the left side, were 9, and in the right side, 9. But this is in T12. There is no doubt about the existence of this beautiful artery. The thoracic artery was present in 38 spinal cords and 32 in the left side and 6 in the right side. This is the right side artery and 2 thoracic arteries coming from left side, this and this one. This is a picture showing a small thoracic artery. The nerve of the thoracic segment of the anterior spinal artery has an average diameter of 0.33 millimeters. This measure was done always at thoracic 5 level. This is a thoracic artery, and it's an injection of the great posterior spinal vein. With this video, we can see several interesting things. This is the posterior aspect of spinal cord. This is the injection of this great posterior spinal vein. And I injected the anterior spinal cord vein, the great anterior spinal cord vein, and look at this. This is very interesting because we can see a very good anastomosis between these veins with the anterior aspect of the spinal cord. I'm going to put them again, and in order to see injection of the posterior, great posterior spinal vein. Adamkiewicz studied these veins also, but he said that the veins are very complex and it needs some time to study it. They are difficult to comprehend, to understand, because the feature of several variants, there is a very important variability in the formation of these posterior veins. For example, this kind of anatomic feature. This is a posterior spinal vein. This is about 1.5 millimeters. And look at this. This is a dissection of this arachnoid. As you can see, in the posterior aspect of the spinal cord, is more difficult to dissect, to separate the arachnoid, and in the anterior, the arachnoid is free. In the anterior aspect, is easier to dissect this arachnoid membrane. So veins are very complex. Now we are trying to make a definition, a better explanation of the venous system of these veins in 100 spinal cords. The conclusions about the great posterior radiculomedullary artery is that is present in most of the persons. Understanding this intricate anatomy and its variations is critical for addressing vascular malformations of the spinal cord. A better understanding of spinal cord circulation will lead to reduced risk of surgical and endovascular spinal and aortic procedures. This study was published in American Journal of Neuroradiology last year, and I was very happy because editors of this prestigious journal asked us to put the one picture of our research in the front of this number of this journal. Thank you very much.
Thank you very much, Dr. Perez. Wonderful anatomical presentation with a lot of interesting tips for surgery. There is some question from Dr. Parek. He's wondering about the media you use for contrast, for injection. I think you mentioned that this latex, what you use, colored latex, is that right, Dr. Perez? The substance you use for coloring the arteries and veins.
Yeah, I'm using latex, right. Silicone. So
Miguel, can I ask one question, Miguel?
Sure.
Victor, that was a fantastic anatomical demonstration. I am wondering, when you were injecting in the vein, you were taking the large vein and you were injecting, and the dye and the silicone was going in the veins. Do they not have valves in the veins, the spinal veins? You see, normally we have valves.
Walls?
Valve. I don't think
Valve.
there is any valve.
So I want to know. No, Ramesh, can you tell him what I mean to ask?
So, Victor, this venous system in the spinal cord, Atul Gol is asking, are there any valves within the veins? Like, peripheral veins will have valves to prevent retrograde flow. So he's asking whether there's any valves within the venous system of the spinal cord.
No, I have not found valves. I have not found any valves.
Okay, so this is different. These veins, there is not a single vein in the body, including peripheral vein, central vein, including the, valves are always there.
Yeah, this is different. This is different. They don't have valves. That's why in dural fistulas and AV malformation, you get retrograde flow and congestion, and that's why you get venous congestion and spinal cord ischemia from these lesions.
Okay.
Interesting, very interesting question. Is there any other question? I have one, but I'd like to make this question after the talk of Dr. Vladimir Benes. Is there any other question? If not, we will move to the next presentation that is going to be done by Dr. Vladimir Benes, who is going to talk about spinal cord tumors, how I do it. Vladimir?
Yes, thank you, Miguel. Do you see my screen?
Yes, very well.
Very good. All right. Hello, everyone. It's difficult to talk after such beautiful images which Victor has shown. It's really great. I'm going to talk on intramedullary tumors, how I do it and what can we expect. Obviously, the most frequent tumors are ependymomas, gliomas, then cavernomas, non-tumorous lesion, and hemangioblastomas. Any other is pretty rare. So we have a series of 200 patients, and I'm going to use them as examples how to operate the spinal cord tumors. All the cervical and lower thoracic I do prone and in the same position as posterior fossa or cervical spine, because it's the most ergonomic and most convenient for anyone. Only the lower thoracic in tall patients and lumbar tumors I'm doing in from the side. You see that this is our scrub nurse and she's normally grown. She's not a Lilliput. And I easily handle her lower thoracic spine from the same position as any other surgery. And this is what, let's say, ependymomas of the chorda equina, that I tilt the table towards myself, and again, it's exactly the same position and exactly the same ease. And this is how we do it in COVID era. We have these nice suits, and we are using exoscope for all this. So majority of the tumors of the cord are cervical. There is a specific group of chorda equina. I'm not going to cover it here. Very few tumors are exophytic. Few ependymomas, very few gliomas are exophytic. Majority of the tumors are really intramedullary lesions. There is a slow development of clinical symptoms since the majority of the lesions are benign. There are very few really malignant tumors, very few tumors which are difficult to handle medically. We always do laminectomy. It's always one above and one below, just to have enough space. The urotomy is either in midline and rarely on the side of the lesion. It's really exceptional. Most frequently, it's midline. We then insert the monitoring electrodes because that's a must. Spinal cord cannot be operated without intra-op monitoring. Then I dissect the arachnoid membrane, which I keep open with hemoclips attached to the dura. So the field is quite clean and devoid of any arachnoid membrane sustentaculus and anything else. Define the lesion extent, of course, where it is. Define the midline, which sometimes may be difficult. The best mark are the entering vessels and that little line which you see at the dorsal aspect of the cord. Then cut the ependyma, and that's all. The myelotomy is a completely wrong term because sharply only the ependyma is cut. Then I open the cord in the midline. You can open it nearly like a book, pretty cleanly and easily, and you are not cutting anything there. When the dorsal surface of the tumor is exposed, then I use ependyma dura stitches to keep the cord open, to not to move the cord at all. Of course, bloodless field, never coagulate on the cord surface. Find the tumor cord plane, which sometimes might be difficult, especially at the top and at the bottom of the lesion. Dissect the tumor, and of course, obey the electrophysiology. If they don't like it, go elsewhere or go to the other side of the tumor. Then whenever it's midline approach, we suture the ependyma. I know that someone is suturing the arachnoid as well. I do not do it. Well, specifically ependymoma midline and its midline approach, despite the fact that not all ependymomas are in the midline. I will show you very shortly. Not myelotomy, as I already have said, on sharply only the ependyma with scissors or knife. Upper and lower aspects are difficult. Cyst always helps, which is obvious. Low grades, I'm not talking about the high grades, we have only had one. Those are usually partial or subtotal resections, and again, leave the cyst wall behind. If we all are resecting the cyst walls in the cerebellum, do not do this in the spinal cord. Hemangioblastomas, there is a good plane of dissection, usually the best plane of dissection, but you must handle the lesion in the same way as the AVM. Keep the draining going as the last, and never ever enter the lesion because you never ever will be able to control the bleeding from hemangioblastoma. Cavernomas, usually through the surface area where you see them on the surface of the cord, and they are not always compact. There are quite frequently all those post-bleeding changes, and cavernomas are not that well defined as in the brainstem or anywhere else. Of course, coagulate only the lesion vessels, otherwise no coagulation. Monitoring and intra-OPMR in very selected cases. So let's go to ependymoma. Here you see the ependymoma. The video is not playing just now. You see that the tumor is not really directly in the midline. It's slightly to the left of the cord. These vessels are very important to keep them intact in the midline. And you see the cord is opening really nearly like a book. The only sharp opening is at the surface, the ependyma. And as soon as you have the dorsal aspect of the tumor defined, then these stitches are used to keep the cord open to enhance the resection of the tumor. Again, you see the preserved vessels at the midline of the cord. Here's another ependymoma like that, finding the midline. Here you see the entering vessels, and here is the little line. So this is the midline where you will open the cord. Again, only the ependyma with the knife. And you can coagulate this dorsal vein. As Victor has just shown, there are always anastomosis, so you can be sure that you will not harm the patient by coagulating the dorsal vein. And then defining and finding the surface of the tumor as in any other. Then opening the cord with the stitches just to keep it open, and slow movements. My old boss told me that all the movements should go away from the cord. So any movement should be directed away from the cord. You see the anterior aspect of the cord, and here is the danger because here you may injure the anterior spinal cord artery, which was shown very nicely by Victor just now. So that is the place where one should be very, very careful. But actually spinal cord tumors surgeries is nothing where you can take the time off. You must be concentrated all the time. So this is the anterior aspect of the cord from within, is suturing the ependyma. Another one, just to show that they are that ependymomas are not really the midline lesions always. This is the midline, and you see that we are very much to the left, and the tumor is within the spinal cord on the opposite side, on the right. And now we are going to dissect this the frontiers of the tumor. Again, all these vessels are preserved whenever possible because they feed the cord, they do not feed the tumor. And usually, quite usually, the ependyma is very nice plane of dissection in almost all parts of the tumor. So you just move the tumor and you just take it away from the cord, not the cord away from the tumor. This is one tumor which was both exophytic and our image. It's now already dissected, and you very nicely see the exophytic part of the tumor, and here is still quite a lot of intramedullary portion. So this was very, let's say, combined tumor, not the torpedo shape like ependymoma. This, you see DMR, that it was not really very well understandable where is what. So this tumor took quite a lot, and it was over many etages, but still the patient is doing well. These are the rare exophytic ependymomas before and after, but do consider that these tumors which look like schwannoma or meningioma are by its behavior intrinsic. They always alter the ependyma of the cord. Another one which is rather easily to be removed, but yet again the ependyma will be affected at some point. Astrocytomas, you see the tumor here, and again it's the same, cutting the dorsal midline ependyma, then getting to the tumor, and then all these tumors, it's sometimes difficult to find the interface between the cord and the tumors. In some places it's easy, so it differs, and one must decide on the spot how radical the surgery will be, and quite frequently it's only subtotal. You see again the preserved vessels traversing the midline or the midline vessels, and you see that this is the portion of the tumor where the interface is very good, but very soon it will disappear and we shall lose our way, and then it's up to electrophysiology, experience, and bravery of the surgeon. So you see that we leave behind part of the tumor without any hesitation, because these tumors usually are pilocytic and very, very slow growing, sometimes not even growing at all. This is something different. This is an higher grade astrocytoma. You already see it on the surface, dissecting the arachnoid, and then again through the midline, but you will see that this will be like glioblastoma in the supratentorial compartment with considerable bleeding, you see it, and with rather loss of any orientation. The only orientation at this point was electrophysiology, that they told me whether I harmed the patient or not. And actually only at the end, I was somewhat satisfied with the resection, and the patient survived for something like 8 years. Then he died of drop metastasis of this glioma. You see that the resection was rather effective at this point. We do not do those decompressions and these things. I don't think that it really helps. This is a partially exophytic low-grade glioma, and it's only about recognition that we are operating on a glioma, and then finding the good plane of dissection between the spinal cord and the tumor. And obviously it's better to leave a piece behind. This is a patient who was operated on some 12 or 14 years ago. There is a remnant, but he's still doing well without any symptoms. cavernomas. Some of them do have the same venous anomaly as the brainstem region, and of course here, even here, the venous anomaly should be left behind and not harmed. This is the anterior quadrant of the cord. You see the stitch which is put into the dentate ligament, and the cord is rotated so that one gets rather easily even the anterior quadrant of the cord towards your vision. It means backwards. You see the cavernoma, and it's already seen here after cutting the ependyma that the delineation of the cavernoma is somewhat different from those seen elsewhere, that it's not as compact as the other cavernomas in other regions, and that sometimes one is not really sure whether he has resected the whole cavernoma or not. This is another one. This is a nice one, which is very well circumscribed with the dorsal vein and protruding from the cord, so it's very easy to cut the ependyma all around the lesion and dissect the lesion. This is the cavity after the resection, and since this was done from the midline, the ependyma again is sutured. This is another cavernoma. It's really upper cervical cord, C1-2 region. You see the cavernoma, which is located anteriorly. There is only a small shape of the spinal cord left behind, and the approach again is through the midline with preserving all these midline vessels whenever possible. The cavernoma is dissected and resected in the same way as any other cavernoma. Fortunately, this one is not the disrupted case. This is a very compact lesion, which was rather easy to resect, rather easy. When one was directly there, then it was easy. This is after, and actually you see that the cord is nearly divided in two. Still the boy, which is who is like 17 years old, is symptom-free. Another cavernoma on the dorsal surface, so it's rather easy to get to the lesions through the midline. And again, you see this tissue, which is like the consequence of hemorrhaging of the hemorrhage, and this should be left behind. But then you see the cavernoma itself, and it's not really that compact and that sure of resection as in other regions. You see that this is rather bloodier surgery than one would appreciate in the cord. Again, sutured ependyma. Hemangioblastomas, they have the best interface between the spinal cord and between the lesion. You have the cysts in hemangioblastoma, so you take advantage of that. There is very prominent draining vein. Of course, this must be left until the very end. And you see the interface between the cord and the hemangioblastoma. It's always very nice. It's like a jelly sometimes. And if you follow it, you really may be able to circumscribe the whole cavernoma, the hemangioblastoma, and then cut the vein at the end. The only thing is not to enter the lesion, not to start the bleeding there, because one will never be able to stop the bleeding. Another one, again, you see the vein, which is directly in the middle of the lesion. The lesion is not that small, but again, there are cysts which would help, and ependyma will be cut only just on the lesion side, away from the cord. And again, you see a nice plane of dissection between the lesion and between the spinal cord. It goes always well if you keep the vein until the very end. If you disrupt the vein, then it's bleeding like hell. This is one of the hemangioblasts, which was more on the anterior side of the cord. So again, the traction by the dentate ligament. You see the atypical vessels at the upper part of the lesion. We are looking reversely. So this is down, this is up in a patient And you see that the hemangioblastoma is partly outside, and it was rather easy to dissect the hemangioblastoma, safe for the remaining vessels at the top of the hemangioblastoma, because they looked more or less like arteries, and I had to use ICG to check where they go, whether they do not feed the normal spinal cord, and only then did we cut them at the end of surgery. Another hemangioblastoma, which is in the CC region. You see that this is really a spinal cord hemangioblastoma, and here are the olives and here is the calamus scriptorius. Again, the same draining vein, and after the surgery. And you see that if you keep these tiny vessels patent, you will not harm the patient, with no respect to the region and no respect to the volume of the lesion. Very rare lesions, actually, the spinal cord tumors and the cavernomas, if I could call it like that. In the 10 years period, they compose only 0.3% of our surgeries. So it means that there are like 8-10 surgeries per year. And that's also, these surgeries are never routine. Never ever are they routine, and never ever can a surgeon relax thinking that it will be easy. Something like 80% of the lesions can be resected either radically or subtotally. But of course, there are partial resections. Those are the gliomas. And sometimes the number now is much, much lower, the biopsies. This is the first 66 patients in the beginning of the 2010. And this is probably the most important slide. What can one expect as to the surgery? The patients who are coming in a good condition remain in good condition 3 months after the surgery, and of course they are in good condition 1 year after the surgery. McCormick grade 2 is increasing, but that is the only movement from the patients coming in McCormick grade 3. These improve into the McCormick 2. They very rarely or almost never improve into McCormick 1. Once you have some neurological deficit coming in, it's very unlikely that this deficit will markedly improve. It will improve, but not really markedly, allowing you to cross the lines between McCormick grades. And of course, the patients who are coming in a wheelchair do remain in a wheelchair 1 year after the surgery. So the only improvement can be promised to the patients in McCormick 3, because those are the patients who really may improve. So in conclusion, the patient after the surgery should be the same neurologically as before the surgery. In all these tumors, the neurological deterioration is not really necessary. You may warn the patient that there might be some increased or minor post-surgical neurological deficit, but this one will definitely improve. The patients shouldn't have the permanent decrease of function after the surgery. That's probably a must, and probably the prerequisite for surgeries of spinal cord tumors. Of course, the lower the attach of the lesion, the more difficult. The most difficult tumors are conus medullaris low-grade tumors. Sometimes there are tumors where you are happy to get at some biopsy. Fortunately, there are not that many of them. And in general, I like to call spinal cord tumor surgery a surgery directed by function. You have an electrophysiology there, and you really obey the electrophysiology. They are the ones who command the surgery. They tell you when to stop. They tell you when to go forward. They tell you when you should tend to other aspects of the tumor. They even tell you when you should leave for half an hour the surgical theater and come back. So these are the most important people during the spinal cord tumors surgery. Let me make a little advertisement, since I've been talking about cavernomas. we have published a book about the cavernomas, and all those spinal cord cavernomas are composing one of the chapters of the book. Thank you for your attention.
Thank you very much, Vladimir. Wonderful presentation. I like to enhance the large experience of Professor Benes, and also thank you for giving us many tricks about that kind of digital operations. I have, from the audience, I have 3 questions. One of them is about your tricks to localize the lesion when the lesion is at the dorsal aspect, but underlying. Do you use ultrasonography or what kind of strategy?
We don't use the sonography. We use the normal C-arm, and the trick is to count the levels properly on pre-op images. Be it CT, be it MR, be it normal X-ray, whatever, you need really to count the vertebrae well. And then still you may miss your lesion. You may see the normal cord when you open the dura. So quite frequently we are doing these surgeries in our intra-op MR suite. Should you miss the tumor, should you be unsure, then you go into MR directly in the operating theater. This may help.
Thank you very much. Second question, in regard to long laminotomies, what kind of fixation do you use? What kind of strategy, in which cases?
You mean what?
Laminotomy and fixation.
How do we reconstruct the laminotomy? Or I don't hear you well, Miguel.
Yes, the question is about the technique for fixation after laminotomy or laminectomy. In which cases do you undertake such a technique? I mean, I suppose young patients, cervical region, and so
definitely
microplates. This is the
we use microplates to reconstruct the laminotomy. We use laminectomy extremely rarely. In the old patient in upper thoracic, then I would do laminectomy. But almost in all patients by now we are using laminotomy, one above and one below, and we reconstruct the laminotomy with plates and screws, of course.
Thank you very much. So I have a last question after your talk and after Dr. Perez's talk regarding the great posterior radiculomedullary artery. We assume that is a danger, and mainly for intradurally extramedullary tumor. But I know you also have a large experience, Vladimir, in that kind of tumor. My question is, in which cases, and taking into account the variability of the great radiculomedullary artery, in which cases do you think it's reasonable to get angiography preoperatively?
In tumors, we do not do angiography at all. And I believe that if there is a need to sacrifice the artery, those are usually schwannomas and very rarely meningiomas, not intramedullary tumors. You do not sever any artery during intramedullary tumors resection. You preserve them. That's nearly a must. And we do not take any measures but temporary clipping and electrophysiology. If the artery looks suspicious, we put the temporary clip and we wait for 5-10 minutes just if something happens with electrophysiology. Victor, it's a question more to you.
Yes, Vlad, thanks. Well, the great posterior radiculomedullary artery is very deep in angiographies in the cord. But I think in all the posterior aspect of the spinal cord, especially those coming from 10 and thoracic 10 to to lumbar 2 or 1, we need to take care of artery. It is coming in the is coming from the thoracic 12 level in both sides. There is no preference. In the 50 spinal cord studies, it is coming from that. So that's about the care we should have, or if we need to make an angiography preoperative study. It's difficult to find this very small artery. This is about 500 so it's really, really small, and sometimes about 300 micras. It's difficult to see in the angiography. But it's a good question, because every surgeon that is doing procedures in the spinal cord should need to take care about this small artery.
Thank you very much. I think we have to move to the next presentation because we are a little behind the schedule. And Dr. Karan is also here, who is going to punish me as moderator. So let's move to the next presentation.
Hi, everybody.
It is for me a great honor and great pleasure to ask Professor Goel to start his presentation. Always, you know,
I think it's me. I think.
I'm creating a debate. So, Atul, go ahead with your talk.
No, it is Ramesh.
No,
Miguel,
Ramesh.
it is Ramesh lecture now.
I think it's mine, Miguel.
Sorry? Oh.
It's Ramesh lecture now, and then mine.
Thanks.
Go ahead, Ramesh.
Oh, yes.
Thanks very much.
Sorry.
I'm going to share my screen.
Yes, Dr. Ramesh Nelson. Sorry.
No, it's okay. All right.
I asked Dr. Nell to start his presentation before Dr. Goel on spinal vascular lesions.
Thank you. Thank you, Miguel, and thanks
I apologize.
No worries. Thanks, Miguel, and thanks, my friends. And congrats to Imad and Vladimir for leading our wonderful team. Good day to everyone. I'm going to talk about the spinal vascular lesions and to give you an overview and some of the common lesions we treat surgically. So we start with the typical case. This is a guy who was in his late 60s, retired social worker. As it happens with the majority of these patients, they get treated by neurologists for some time, then they get referred to the neurosurgeon. This guy was having weakness of his left leg. Rather uncommonly had a rapid worsening of his left leg power. On history, he did have some weakness even before, and by the time he was sent to the emergency department, he was catheterized, and clinically then you could see that he was myelopathic, hypertonia, hyperreflexia of the lower limbs, and this is the MRI scan. This is what prompts further investigation and neurosurgical referral. You can see the lower end of the spinal cord towards the thoracic spinal cord. You could see some flow voids and the signal changes within the spinal cord. This is a typical presentation of most of the spinal vascular malformation. So spinal vascular malformations, there are different classifications. I'll keep it simple and try to stick to one or two classifications which we can use more commonly, because it's important to know how it's classified and how it's categorized, so that you get an idea about the general classification. Cavernomas, Vladimir has mentioned about it already, and it's similar to brain cavernomas. And AVMs are slightly different, and they can be a juvenile type or a glomus type, which is more of a compact nidus. And perimedullary fistulas are also not common, but it is something which you encounter occasionally. But more commonly you see dural AV fistulas in the spinal cord. So in fact, majority of patients will have dural AV fistulas and some will have a glomus AVM. So almost 90% of patients will have one of these two lesions. So this classification by Anton Spetler is more practical and gives you an idea about the 4 types of AV malformation in the spinal canal. the dural AV fistula, which we commonly see, and the glomus AVM, and then there's the juvenile type of AVM, which you see in a young patient. Because it's congenital, it can be distributed throughout the spinal cord and can have multiple feeders. And the last type 4 is the pile supply, pile AV fistula, which can be an intradural extramedullary lesion. It's on the surface and is often a fistulous communication between a pile artery and the vein, and we'll see one of the examples for that as well. So coming to the spinal AV dural fistula, the general majority of patients do come with this progressive weakness, paraparesis, and sensory disturbance, and bowel and bladder impairment, which may go on for months to years. And most of them are men in their after 40 years of age, and they can get lower thoracic back pain, but radicular pain is not very common. Sometimes you can get painful radiculopathy from this lesion. But one thing which you have to remember is that some patients may get an acute deficit whenever they change their posture or do some activity, which essentially reflects the venous congestion and then lead to an acute deficit. And this is one of the critical thing about diagnosing the lesion. When you see many patients, there may not be a clear-cut vascular pathology on the scan. You only see some demyelination on the scan, and they get treated by neurologists. And also you may find some degenerative disease within the spine, like stenosis, and you'll attribute everything to that. And then these lesions can be missed. So high index of suspicion should be kept. And more acute presentation, like Foyce-Alajuenin syndrome, where you get thrombosis of the vein leading to acute worsening, is unusual. What about AVMs? Could be similar, but they can present more acutely. We'll see some examples here. But if they hemorrhage, they typically present with a subarachnoid hemorrhage. Or they can present with a spinal cord hematoma, leading to paraplegia or quadriplegia, depending on where the location is. And those with presenting with subarachnoid hemorrhage often present with a typical subarachnoid hemorrhage you see for aneurysms of the brain. So if you don't see any aneurysms on the cerebral angiogram, you've got to rule out a spinal vascular malformation. So nothing much to say here. Investigations, depending on the presentation, you may want to get a CT for subarachnoid hemorrhage, but otherwise standard investigations are MRI scans and vascular imaging. Could be MRI or CT angiogram, but the standard of investigation is often a spinal angiogram, which will determine the nature of the flow within the vascular malformation and the type of the vascular malformation. And there are different treatment, but we can only talk about surgical treatment. I will skip all the endovascular, but one has to know that often surgical treatment is not enough and may not be possible in many cases, and in such cases may require endovascular embolization. And in many cases may need radiosurgery or combination of techniques, and some are inoperable, so we have to accept that fact. And surgery for dural AV fistula is fairly technically straightforward. Especially you do it when you have a slightly more tortuous vessels and multiple feeders where endovascular treatment is not an option. Endovascular treatment may be a good option if there is a clear-cut surgical target without any risk to the blood supply to the spinal cord parenchyma. So you can consider endovascular treatment if there is a suitable charge for it. Or if some patient factors like obese patients and you don't want to do an operation for another contraindication, then you could consider endovascular treatment for these sort of conditions. There are more and more advancement in this field with more materials and macrocatheters where you can do selective angiogram and embolization. So these are lesions which can be treated endovascularly, but not all the cases. So these things which I often look carefully, you got to have neuromonitoring, and Vladimir insisted on for spinal tumor. Similar to that, you got to have neuromonitoring to look at the function. And the most important thing in this slide is the analysis of the imaging, the vascular imaging, and which vessel is supplying what, and you have to make sure that you got the correct level. And all the other adjuncts like indocyanine green intraoperatively will help you during the operation. The other thing which I want to mention is that even though you may have done a good operation, patients may not become completely asymptomatic. They will carry on with their symptoms for some time, and even the MRI changes may take months to get better. So this man who had this fistula went on to have an angiogram, which you can see is a fistula fed from the left T11. And this is where the fistula is, near the dural root sleeve of the T11. and then the venous reflex goes back to the pile veins, and then they get congested, and that's what leads to the spinal cord ischemia. So this is the diagram to tell you how the fistula develops around the dural grid sleeve. Most of these are acquired lesions. I mean, we don't know exact pathology or the etiology of it. Could be traumatic. And then they connect with the pile veins, which then become arterialized. Arterialized means they become very strong, but then eventually the blood stagnates and the vascular supply to the spinal cord suffers because there is less arteriovenous gradient and the blood supply diminishes. So intraoperatively, you can find that this is the left T11 and the root is here. Left T11 goes through the dural sleeve, and see how thick these vessels are. They're quite strong, not like a normal vein, and this is where the fistulous component is. So all you need to do is to confirm whether this is the culprit. You may have to do test occlusion to look for distal turgidity of the veins and the flow of the vessels, and then you may want to consider clipping off or dilating that fistula. Here I used a clip. Normally, depending on the turgidity and the strength of that vessel, you may use normal clips or you may use aneurysm clips. Here I used an aneurysm clip. So just checking with the Doppler in terms of the flow reversal and the kind of flow after the clipping. Just going to fast forward the picture a little bit. So finally, it's all cauterized, and you cauterize the side of the dural fistula as well. So this is all cauterized, so you don't have any more fistulous component there. So it's fairly straightforward, and this is straightforward when you have a single fistulous feeder. If you have multiple feeders, it can be a problem because sometimes you can miss it. So this is a preoperative scan where you can see that the signal change within the spinal cord. It took almost 6 months to get better, and you can see if you look carefully in the postoperative MRI scan after 6 months, there are some vessels you see, because some of these arteriolous vein may not become normal and you still see them. That doesn't mean that the fistula is recurring. Another guy, 72-year-old man with a history of lung cancer, difficulty in walking, trouble with his bladder function, and had neuropathic symptoms, so he couldn't walk. He was almost wheelchair bound. Again, you can see the vessels in the lower spinal cord with the signal changes. No wonder he had bowel and bladder impairment. So here the fistula is from the right L1 radicular branch. You can see it's fistula is there, and then the retrograde venous reflex going all the way up, really going up. So after surgery, it took 6 months for the spinal cord to get better, and you don't see any vascular abnormality there as well. But these patients, as Vladimir said, they don't get completely normal. Once they are myelopathic, they will always have symptoms, and as we know, spinal cord myelopathy patients, they often have waxing and waning of the symptoms, and that doesn't prompt you to investigate them intensively, because often they will get better and they will stabilize and they get worse. But occasionally you may have to consider re-scanning and then re-angiogram. For example, this man, who was a 60-year-old chauffeur, husband of a radiographer in a hospital here, came with a lower limb weakness, and he had trouble in his lower limb with altered sensation and a reduced bladder sensation. And he did have myelopathy as well. And you can see in the MRI scan, you can see multiple vessels in the dorsal aspect of the thoracic spinal cord. So the fistula was from the T6 on the right side. You can see the fistula causing the retrograde venous flow downwards here and going up and down. But the one thing which I want to show here is that when the radiologist does a diagnostic spinal angiogram, it may be useful to leave like a metal artifact there. This is a coil, which will be useful for your localization, because sometimes in the thoracic spinal cord, even in the cervical thoracic junction, it may be difficult to get the level correct. So this is the coil you see here. My hook is in that foramen there, so I know exactly where the lesion is. So this is he had symptomatic worsening over the time, and I did a further angiogram. There was no fistula recurring. You can see the clip there following the clipping, and eventually this month he came back with the further symptoms, but the scan looked fine. There's no further recurrence, so it didn't need any angiogram. So this is what happens with some of these patients. They will have symptomatic recurrence without any actual recurrence of the. But this one is different. This lady was in her 60s and had a diagnosis of demyelination by the neurologist for 2 years, and then eventually referred to me. Then this is a scan from 2010, because the scan is almost normal apart from the signal changes within the spinal cord. So then when she came, she had more florid appearance on the scan. You can see the vessels, and the diagnosis was most very obvious. And the initial diagnosis, this is a scan after the initial ligation of the fistula, because the fistula was at the left T8, the right T8. You can see the fistula at the T8 and then going down all the way. So the initial diagnosis was a dural fistula from T8. Then about 4 years later, she came back, and you could see still some veins there, and even though spinal cord shows some thinning because it's related to the initial myelopathy, she had another angiogram. This time it was T5. There is a supply, and there is some focus of enhancement the vessels around the lower spinal cord here. So essentially the original diagnosis should have been a perimedullary venous fistula, and this was probably missed. And then that's why she had a recurrence. Again, she was taken back to theater, explored the spinal cord, and all the perimedullary fistulas were disconnected. And following the surgery, she had a further angiogram, which didn't show any further fistulous communication from the T5. Let's look at 2 more cases just to give you an idea about the modes of presentation of some of these cases. This lady in her 30s came with sudden onset of headache, typical like a cervical hemorrhage, and she had chest tightness. And the CT scan revealed cervical hemorrhage. Because she had chest pain, she also had a CT aortogram to rule out any aortic dissection, which she didn't have. But CT angiogram, everything was negative. Even the cerebral angiogram was negative initially. So this is the CT scan. You can see the blood is mostly in the posterior fossa around the CV junction, but you could see some blood in the ventricles as well. At the MRI, when we looked at it later on, you could see some hematoma around the front of the spinal cord behind the C23 level. So this initial angiogram was reported as negative because people were looking at the cerebral angiogram, and when you reviewed the angiogram and then repeated the angiogram, you could see that there is a blush around the C23 vertebral artery, and there is some stasis of the blood in the front of the spinal cord here. And also you can see that anterior spinal artery is quite prominent. So I wasn't sure what exactly it was, so it exploded, and you could find that there are some tributaries from the C23 level from the vertebral artery going into the front of the spinal cord. So this is, as Vladimir mentioned, you have got to cut the dentate ligament to mobilize it. And there's some optimum pressure on each part of the spinal cord. Cervical spinal cord has got some threshold for mobilization, and thoracic spinal cord and lumbar. Lumbar will have more maneuverability in terms of mobilizing the spinal cord. So here I'm just checking the front of the spinal cord, and here you can see the vessels are, you can see in the front of the spinal cord there is fistula here. I wasn't certain whether the anterior spinal artery is contributing to it, even though I could not see anything on the angiogram pre-operatively. Even intraoperatively I could not see any further because I couldn't really rotate the spinal cord anymore. So eventually she did have disconnection of those 2 feeders, and then on further cerebral DSA, not DSA, the endoscopic angiogram, there's no further fistulous communication in the front of the spinal cord. So again, this is a fairly new case from 2 months ago, so I'll have to wait till she gets another angiogram to see. Some lesions are inoperable. This is a young man in his 40s, came with weakness of his legs and trouble with walking. You can see an extensive AVM of this spinal cord and the paraspinal area. All this right side is all different to the left side, and a lot of AVM vessels extradurally and intradurally, causing spinal cord compromise. This is what happens with some of these congenital lesions like metameric AVM. So there's not much we can do. He did have some embolization to reduce the flow, which stabilized him. So I didn't really have to operate him. I've been watching him for about 6 years now. The last case is slightly complex. A 30-year-old female 12 weeks pregnant. She was first trimester, not first trimester. She was primi gravida, and she was a medical legal defense lawyer here. And on the weekend, she was bending forward and felt some cramping pain in her leg, and initially seen by GP, and went to A&E. Then she was discharged because it was thought to be a sciatic pain. Then over the weekend she worsened. Then gradually her symptoms progressed. The pain worsened. The leg got more weaker. She had sensory disturbance in her saddle area, and also had trouble in emptying her bladder. So eventually she was sent to the hospital, and her right side was more weaker than the left side. And this is a scan. In the lower end of the spinal cord, you can see a hematoma with some vessels around it. So you can look at the MRI scan. The hematoma here, some vasculature around it. It's very likely an AVM of the conus. You can see the hematoma here. And so you've seen the anatomy of the artery of Adamkiewicz very clearly from Victor's talk. So her AVM was being fed by this artery of Adamkiewicz. This is a typical hairpin loop which Victor mentioned, comes down, and around the corners it is an AVM. You can see the feeders. There's one major feeder and another small feeder. I wasn't sure about this collateral coming back, going retrograde, was connecting to this, but tried every possible views to check whether there's any connection, but I wasn't sure. So she was then taken to theater. So this is the appearance for AVMs, and there can be larger or smaller AVM. This is a compact AVM of the cornus. See, cornus is a very critical structure with all the control centers and the fibers for the lower bladder and bowel function. And you can see the AVM here, and I'm holding on to the ligament to rotate it. And this part of the spinal cord takes more maneuverability. And you just have to rotate it to see whether the anterior feeder is just going to speed up. So I'm just checking for the feeder, which coming from the front and supplying the AVM. And there are two feeders. One goes here and the one comes here. So two feeders I could see. And then once you check with the ICG angiogram, you could see it's fed by the anterior branch. And then that is the primary feeder. So then once you establish the feeders, this is disconnected, and the AVM surgery is similar to the cerebral AVM. But the margin, error of margin, is very, very small here. You cannot really move away from the vessel wall, whereas in cerebral AVM, sometimes you can go just around it. Here, because all the fibers are going nearby, you just have to be so precise with your excision here. Let's just speed up. And in such large AVMs with the subpile location, Vascular has advocated subpile resection, where you just remove the superficial part of it, and that should be enough to treat such cases. Here there was an intramedullary hematoma. So as you get in cerebral AVMs, if there is one surface which is hematoma, that helps you during the operation. Similarly, I did the resection here. So again, it's generally being resected without, and again, as Vladimir mentioned, you don't move the spinal cord at all. You just move the lesion, and no traction on any of the neural structures. And it's got to be really precise and with high magnification. So you're going to move it forward. So, I mean, here the clot is inside. The dilemma at that time was whether to remove the clot, because it's very organized, and I thought removing the clot would have caused more damage, so I didn't do it. So the ICG then subsequently shows excision of the lesion, but there was another part of it being supplied from the back, so which again then had to coagulate. So here I didn't resect it because its underlying is normal parenchyma. So I can only use the bipolar to coagulate that feeder. So that is a feeder coming from the front, and again, that is all coagulated. Well, I mean, she had a good outcome. She remained stable immediate post-op, then had some worsening during the immediate post-op days. but eventually she recovered, but she was still on catheter for some time, then went under the urologist for long-term rehab for her bladder. Then even when she came, she could not walk, and then she started walking with the crutches. When I phoned her about, I think 4 months ago now, she is not using any crutches anymore, and her bladder is better. She's continent, but still under the urologist. And we did recently done an angiogram because we didn't do a post-op angiogram immediately after because she was pregnant and wanted to reduce the radiation. And this angiogram shows there's no further AVM. So to conclude, overall, I have to say these diagnoses can be missed. Got to be really careful not to miss these sort of subtle AVMs and dural fistulas. The second thing is have a detailed analysis of the pre-operative imaging, angiograms and MRI scans, have a discussion with the interventional radiologist, and some lesion may require multimodality treatment, like radiosurgery or endovascular treatment. And you have to admit that some lesion may recur and some may be inoperable. That's it. Thanks very much. Thank you.
Thank you very much, Ramesh. Wonderful presentation, wonderful cases dealing with this difficult pathology. We have time for 2 questions. One of them, when do you carry out surgical exploration in case of suspicion of dural fistula and negative angiography? Do you do exploratory laminectomy?
So, no, I haven't done any exploratory laminectomy in case of negative angiograms. And the reason for suspecting is either you should have some evidence from the MRI scan or an angiogram demonstrating that there is an abnormal fistulous communication. If you don't have it, if you don't have any positive angiogram, then it's difficult. If you have even MR or CT angiogram shows you the fistulous communication, then it's, I think, reasonable to explore it. But if there is no angiographic finding, either CT or MR angiogram or even a DSA, then it's going to be difficult to explore it blindly.
Thank you very much. We have one question from Dr. Suresh Nair. The question is, what is the plane of location of dorsal and ventral veins and its significance in presentation and management of dural AV fistula?
So that's a good question. Yeah, that's a good question because, as Victor mentioned, these are very complex in the spinal cord, and there is no definite pattern or nomenclature or grading or classification to it, but they're all very complex. And with this dural fistula, they already get engorged and become arterialized. Especially in spinal fistulas, you will not find where the actual fistulous communication is. There's one case I showed where there was a recurrence when the initial diagnosis wasn't correct. I had to coagulate all the pile engorged veins. I also you have to make sure that you don't damage the normal venous supply. So arterialized veins, you may have to remove to avoid that fistulous communication. And often the ventral veins you may not be able to see from the posterior aspect. So with the fistulous communication, because it's a circumferential coronal venous supply, you get engorgements of all the veins. So the main thing is to have a disconnection of the fistulous communication. That will resolve the engorged veins, the anterior and the posterior aspect of the spinal cord. The crucial thing is you have to disconnect the venous supply at the root and at the dorsal sleeve.
Thank you very much. So now I hand over to Vladimir Benes, the moderation for the next speaker. Thank you for the presentation, the superb presentation of
Thank you.
the initial lecture. Vladimir.
Okay, Miguel, thank you very much. It's a pleasure to take over from a very good friend of mine, and it's my pleasure to introduce another very good friend of mine whom I deeply respect, Atul Goel. Atul, do you know the history of Chiari malformation? I'll tell something. Chiari described the malformation here in Prague in second half of the 19th century, and the specimen was preserved in Prague Museum of Anatomy at our university, and it got lost at the end of the World War II when Germans, for some reason, decided that this collection should be moved from Czech to Germany, and the train where the collection was bombed at the border of Czech and Germany. So we shall never ever see the original Chiaris malformation specimen. But I believe now Atul will tell us in his next 20 minutes everything about it. Atul, please.
Okay, my dear friend, Vladimir. I can see Miguel. I don't see Imad around, but he's there. I see several friends of mine. And I want to take you to my world of cranio-vertebral junction, to a wonderful world, to a beautiful world, to a world where our surgery will make the difference. The surgery can give new life to the person, completely new life, or it can completely demolish the person. So you give new life or you demolish. That will depend on how much you are trained in this subject. So when a person comes with these kind of neck, he has different problems in the hands, legs. The question is, one, whether you can do atlantoaxial fixation or not. If you do not want to do, or if you cannot do, please do not touch. But if you can do a good operation, you give new life, new neck, new hands, completely new life to these unfortunate people. On the other hand, you do a wrong operation, you completely demolish, finish, and that they will die a miserable death. So it is important that we learn this area very nicely. Cranio-vertebral junction is a beautiful, it is a miracle of God. It is a magnificent architecture. You see, this is the C1 arch, and see the facet. This facet is the strongest bone of the body. After teeth, they are the strongest in the body. The lateral, the transverse process, the largest transverse processes of the body. Whole spine, this is the largest. There is no spinous process in the posterior arch. C2 spinous process is the biggest spinous process in the whole body. So this is a wonderful, beautiful architectural wonder. This gives flexion, extension, this gives rotation, and there are various, you see there are so many ligamentous mark on the superior surface of the facet. Strong ligaments attach the facet to the occipital bone. On the other hand, if you see this inferior surface of facet of atlas, it is like a naked bone. There is not a single mark of the ligament. So it is the most mobile joint of the body. Atlantoaxial joint is the most mobile joint of the body. Occipito-atlantal joint is the most stable joint of the body. So stability and mobility are the hallmarks, are the premier features of cranio-vertebral junction. For me, cranio-vertebral junction instability means atlantoaxial instability. This occipito-atlantal instability is impossible. Extreme rare situation. Cranio-vertebral junction stabilization means atlantoaxial stabilization. Occipito-atlantal stabilization is absolutely, absolutely not necessary. So we introduced this technique in 1987, as you know, and many of the people in the audience who are dealing with cranio-vertebral junction know this technique. But I can also tell you that the indications of atlantoaxial fixation are becoming so wide that everyone should learn the technique of fixation, because I will now discuss the indication. One screw in C1, one screw in C2. We introduced this technique. Now it is one of the most highly cited technique in the subject of spine. So in 1988, I did this first case. You see the bone fusion. Atlantoaxial instability means atlantoaxial stabilization. No occipital stabilization is necessary. Over the period of 32, 33 years, we have done such fixation, selective atlantoaxial fixation in nearing 2,800 cases. My technique since the beginning involves three crucial issues: open the joint, remove the cartilage, introduce bone graft in the joint, and then do instrumentation. None of these three steps is compromisable. You have to open the joint, you have to introduce bone graft. No way you can do remote control fixation. C2 ganglion anatomically is located right behind the atlantoaxial articulation. So if you have to open the atlantoaxial joint, we had initially, long time ago, described that you can cut the ganglion and then the whole facet joint is in front of you, I think. But nowadays, I don't do this technique in majority of cases. But the issue is, when we describe this, the whole world of lateral mass became open for surgery. The other important issue in this surgery is the vertebral artery. And I will like to discuss the vertebral artery. So vertebral artery, when it comes from C5, up, 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 then it makes a loop under the facet, under the superior facet. Not so much, this is very much, the loop is much bigger here, but this loop is the one which can potentially injure whilst you are putting the screw. So you have to know this loop very nicely. So we had described in 1988 that you divide into 9 quadrants, and upper 4 quadrants are the safer quadrants, but this is not always true. So this is mobile atlantoaxial dislocation. Your direction has to be medial, your direction has to be superior. As regards C1 is concerned, and as regards C2 is concerned, superior and medial. So this is mobile and reducible atlantoaxial dislocation, no controversy for ages that you have to do fixation. You see this beautiful C2 vertebra, this is the superior facet, and this is the inferior facet. You see, they are not in line. All the other facets in the subaxial spine are in line, but this is here, the superior facet is in front, inferior facet is behind. The vertebral artery comes like this in relationship to the superior facet and then turns out from here. So the vertebral artery is in relation. When you put a screw from here in the pedicle, this area of the artery can be damaged, and this is one has to know very nicely and beautifully. So we introduced this beautiful radio imaging technique and modeling. We made models. You see these kind of models, and this can be held right in the hand in front of you during the operation theater. They are made to size, and you can see exactly where the vertebral artery is coming, exactly how it is rotating, and you can introduce the screw as a preparation before operation. And this is a beautiful imaging technique that we use in more complex cases. So because you see here, the superior facet, I showed you here, superior facet, vertebral artery can be in trouble. So you can use the inferior facet. Inferior facet, when the artery is too much medial, you can use the inferior facet, and that can be a beautiful technique. We described this, you see, this is the C1 facet, and you can use inferior facet in high riding vertebral artery. So this is one possible technique that you can use. You see, this is the atlantoaxial instability, facetal instability. The area in the lateral gutter, the bone is quite destroyed. So I've used the inferior facet. This is a wonderful, wonderful technique. The other thing is the vertebral artery loop goes like this, and you have the possibility of drilling and mobilizing the vertebral artery. Like this is the vertebral artery. You can drill the posterior aspect and mobilize and then introduce the screw. This technique is absolutely wonderful technique. Like you see here, the vertebral artery loop is very high. So you mobilize the vertebral artery, and then you see over the vertebral artery, you can introduce the screw. Sometimes you can use transcranial. You see, here the facet of C1 is quite anterior, and to introduce the screw in the C1 can be difficult. So I use transcranial introduction of screw, which is one possibility in cases of little difficult facet of C1. When there is no possibility of other techniques, you can use joint jamming technique. We introduced these kind of spacers for basilar invagination and all those things long time ago, about 20 years ago. We have now started using them very infrequently, but they were first described by us several years ago. When there is, we had also described spinous process screw, spinolaminar screw, laminar screws in this paper in the year 2004. I do not use these screws for a long time. They are not necessary because we have a beautiful C2 pedicle and facet. So this is the spinous process screw that I described in the year 2003 or 2004. So now essentially I do not use occipito-cervical fixation. I use atlantoaxial fixation. We described for the first time occipital screws in the literature in 1987, but occipito-cervical screws implants are absolutely not necessary. They are, on the other hand, less than optimum kind of stabilization technique. The other beautiful thing we described in the year 2004, 2005, that there is nothing called fixed atlantoaxial instability. You open the joint, mobilize the joint, and reduce the dislocation. Like in flexion extension, there is no change in this odontoid process. The treatment was transoral odontoidectomy. We described the technique of opening the joint, facetal distraction, reduction, and realignment of the cranio-vertebral junction. Otherwise, transoral surgery was the treatment for these kind of cases. No question, transoral surgery completely historical, and you can realign the cranio-vertebral junction. Such disruption in trauma where the facet of one atlas is far away from facet of C2, open the joint, manipulate the facet, and realign the cranio-vertebral junction. This is vertical dislocation. You see in extension, it comes down, in flexion, it goes up. Vertical atlantoaxial dislocation we described in the year 2009. When the arch of atlas is broken by bifid like this, there is a lateral dislocation. You see, there is a lateral dislocation in cases with trauma or with bifid arch and lateral dislocation. Now you think as to how you will repair these kind of things, but there is a beautiful technique. Open the joint, distract the facet, realign the cranio-vertebral junction. Rotatory dislocation, nobody in the world knew how to treat rotatory dislocation, but you can give beautiful smile to these faces if you know the technique of opening the joint and realigning the facets. And there is no question that this is a beautiful technique. Basilar invagination is another complex subject. In 1998, we described this classification. At that time, basilar invagination was considered to be fixed atlantoaxial dislocation. For this group, we described transoral decompression, remove the odontoid. For this group, we described foramen magnum decompression. Because the entity was fixed, the treatment was decompression. So you remember this, but we completely changed. And now our concept is that entity is unstable and stabilization is the treatment. In this article, we also said for the first time that there is no need to open the dura when you do foramen magnum decompression. In 2004, we described that this group is unstable and this group is stable. For this, you can do cranio-vertebral junction realignment. Open the facet joint, distract the facet, and realign the cranio-vertebral junction. So there is basilar invagination. No need to do any kind of decompression from front or from behind. Distract the facet and you can do cranio-vertebral junction realignment. Now I have got several hundred cases of this kind of treatment. There is no controversy in anybody's mind, and you should not keep any controversy. Transoral surgery is not necessary. Foramen magnum decompression is not necessary. Realignment is necessary. No matter how inside it goes, you can do cranio-vertebral junction realignment. Instability is the cause. Stabilization is the treatment.
Atul,
so when you see a case with short neck, when you see a case with torticollis, when you see a case with multiple bone fusions like Klippel file abnormality, when you see assimilation of atlas, when you see C2-3 fusion, when you see platybasia, when you see dorsal kyphoscoliosis, what is your interpretation? And I will tell you, whenever you see short neck, there is atlantoaxial instability. Whenever you see torticollis, there is atlantoaxial instability. Whenever you see clipal file abnormality, there is atlantoaxial instability. Wherever you see platybasia, there is atlantoaxial instability. So you remember atlantoaxial instability, you stabilize, and all these features reverse. You see short neck will become long neck, and torticollis will become straight, and this beautiful smile you can introduce this patient. Bone fusions are secondary, never primary. So bone fusion, when you see, you must not start opening the bone on decompression. Decompression is negative form of treatment. When you see assimilation of atlas, when you see C2-3 fusion, your interpretation should be one, and that interpretation is atlantoaxial instability. So this kind of multiple bone fusion, there is no need for any kind of osteotomy. When you see bifid arch of atlas, there is no need to discuss. This patient needs atlantoaxial stabilization, and you will see wonders. You will see absolutely new life to this patient. Even when there is no compression of the cranio-vertebral junction cord, does not mean anything. You need to do stabilization. This lady was a very influential lady, came with breathing disturbance, and you see the bone fusion. There is no compression of the cervical medullary cord. I did fixation, and this lady got a fantastic breathing in the evening of operation and an absolutely new life. Decompression is not the treatment. Syringomyelia, like I talked about bone fusions and assimilation of atlas, similarly, neural changes. When there is chronic atlantoaxial instability, there is syringomyelia or neural changes. These are secondary, never primary. So when there is syringomyelia, one thing you should immediately think there is atlantoaxial instability, and you stabilize. I want to introduce to you a revolution in cranio-vertebral junction. Absolute revolution. The issue of central or axial atlantoaxial instability. Carefully see this, and if you can read this, this central instability is a chronic atlantoaxial instability. It is present in basilar invagination, Chiari malformation, syringomyelia, myelopathy related to spinal degeneration, OPLL, Hirayama disease. All these patients have central instability. If you understand this, you can create wonders in the treatment of these entities. Now you see carefully, there is atlantodental interval disturbance. There is a facetal listhesis. This is type 1 atlantoaxial instability. There is dural compression, neural compression. No question, there is a need for fixation, no question. Now you see carefully, there is basilar invagination, severe basilar invagination. There is no atlantodental interval disturbance, but there is facet of C1 is behind the facet of C2. No question, this needs C1, C2 fixation, even when there is no neural compression. Type 3 is even when the facets are in alignment and there is no neural compression, presence of Chiari and presence of syrinx are indicators of atlantoaxial instability, and they need fixation, and the syrinx will disappear. More than that, the patient will get absolutely new life, even when there is no atlantodental interval disturbance, even when there is no facetal problem, there is Chiari malformation, there is no tight cranial posterior cranial fossa, there is vertical reduction in the posterior cranial fossa, increase in the anterior posterior component of the posterior fossa. This patient does not need any decompression, which is a negative treatment. You do atlantoaxial fixation, you create wonders for these patients. Instability is the cause of basilar invagination, and stabilization is the treatment. Several years ago, I wrote about 510 cases of group A and several cases of group B. Both these need one treatment, one and only one, atlantoaxial stabilization, no decompression. So I have no hesitation to say that I have completely demolished transoral surgery, at least from my own department, for several years. And transoral surgery is nowadays considered to be a negative operation. Another beautiful thing I am saying, that foramen magnum decompression for any kind of decompression is a negative operation, is harmful operation. It is not necessary. It is not necessary and harmful. Never do it. So basilar invagination of all kinds, instability is the cause and stabilization is the treatment. All these things are like mother taking care of the child. Nature takes care in chronic situation, basilar invagination. These are bony problems. Chiari malformation and syringomalia are neural issues. So basilar invagination, syringomalia, and Chiari malformation are all secondary problem, and that problem is will reverse. So atlantoaxial instability, the cause of Chiari, one, that to do this operation is difficult. It is not easy. If you want to do treatment, you have to learn this technique. These kind of tonsillectomy, dural removal, and bone removal are negative complete operation, no question about it. So when there is
Atul,
infection, no
Atul, sorry, Atul,
disturbance,
Atul,
sorry to interrupt you, but I think you missed the message. 5 minutes ago, Vladimir mentioned you have 2 minutes, so we don't want to demolish the.
Okay, no problem. No,
yeah,
no, but just take few slides now. Instead of question, just take 1 or 2 slides are remaining. Can I go ahead? No.
No.
No?
No.
I think you have to, because we have been very strict. We
No
have
problem.
9 presentations, Dr. Atul.
So should I stop?
Atul, thank you very much. It was great.
Okay.
As always, we enjoyed that.
Thank you.
And we now are going to the next lecture, which will be definitely by another good friends of mine. Salman, please.
Thank you, Vlad. It's really a pleasure to be here. And I think it was brilliant talks by earlier speakers. Atul, as always, good to see you. Great job. And I see lots of good friends, Miguel, Victor, Imad, and obviously Ramesh and all the other friends. I'm grateful for this opportunity. So let me just screen share. Can you see my slides? Yes, Vlad?
Yes, Salman, it's okay.
Okay. So basically, I'm giving a talk about one of the most common procedures that we do in neurosurgery, which is about anterior cervical approaches and the anatomy related to this. The rationale for anterior decompression is obviously it's direct vision. You've got herniated disc, osteophytes, OPLL, and sometimes interbody fusion when required. The goals are for decompression, stabilization, and indications include the degenerative conditions, trauma, tumor, and infection. The types of ventral approaches are various, but 2 most common approaches that we can take is either ventral and the other one is anterolateral. So basically, one is coming behind the carotid artery, whereas the other one comes in front of the carotid artery. This is the most common approach that we use for our routine cases. So this is the approach we take. So if this is the front, so thyroid is here, trachea is here. So we push the thyroid and trachea medially, and we go push the carotid laterally. And this would be our track that you'd be taking. Esophagus is also pushed medially. So these are the different types of surgeries that we can do when we're doing anterior cervical surgeries. The advantage is obviously that you're addressing the pathology where it is, and so it's easy to decompress. And it's good for all kinds of postures. It's very simple. You don't have to cut the muscles. Risk of infection is really low. The structural graft fusion is very easy to perform. And you are following the tissue plane. So there is no muscle cut. It's well tolerated, less painful and posterior. And majority of the centers are now doing this as a daycare procedure. History goes back to Smith Robinson, Cloward, Bailey, and Bagley, and this all has been going on for last 80 years or so. Relevant clinical anatomy, so muscles, there are 2 groups of muscles. One is superficial and obviously sternocleidomastoid, and our deep muscles, and there are triangles, which we all know of, the 3 triangles that we generally study. And then you've got deep muscles, and these are the important longus colli muscles that you need to push laterally and dissect in order to put your retractor underneath, which in majority of the patients we perform. So I think it's important to understand its relationship to the vertebral body. The body of the hyoid bone is important element. At the same time, you've got the laryngeal prominence, you've got the cricoid cartilage, there's a lamina of the thyroid. So all of these have got relevant reasons that they are there, and they make our life easy if we don't have an image intensifier to start with. But ideally, you should also double check all these measures with the image intensifier. So you need to be careful what's underneath and where it's coming from. So if you look at this, so for example, we take the skin off. So if you've got you have platysma on both sides and you've got the superficial muscles, and once you go in and take the superficial muscles out, then you've got the longus on both sides, and eventually you're left with the raw bone itself. The relevant anatomy, obviously we're going to be talking about the vessels, nerves, and viscera, and the nerves, which are two important nerves that go from here, is the vagus, and vagus gives rise to the recurrent laryngeal on the right, which goes underneath the subclavian, whereas on the left you can see it goes straight up, and this curve obviously comes straight up from here. So there is a difference in recurrent laryngeal nerve on both sides, and visceras are important in this area. Of this, esophagus is the most important one. The vascular anatomy is the anterior jugular system. You come across it, and the important thing is you make sure you dissect in between. And if it's a single level, it's straightforward. If it's more than one level, sometimes you may have to tie a vein or coagulate it, or may have to tie one of the arteries which come in your way if you're doing multi-level procedure. Thoracic duct usually comes down at the lower end and curves in and enters here, and you need to be wary of it on the left side. The vertebral artery, it's important to understand, if you know the anatomy, that it enters from C5 in 7%, and C6 90%, and C7 in 3% from the foramen transversorium. So, and there is an aberrant course in 2.7% of these patients. So it's important to understand it doesn't enter the C6 foramen transversorium every time. So 1 in 10 patients will have a different entry. So you need to be wary of that. The glossopharyngeal, hypoglossal, vagus are important. We talked about recurrent laryngeal, so one on this side and one on this side, and you need to be careful. And they lie underneath the longus coli, and you need to remember that. The superior laryngeal nerve, C3-4 level. The superior thyroid artery is at the same level as well. The recurrent laryngeal nerve is on the tracheo-esophageal groove, as we talked about. On the right side, it may come across at C5-6. And may not recur. So that's important to understand as well. So when you're operating, you need to be careful where exactly this is on the right side. Majority of the right-handed surgeons operate from the right side. So if we see this, so this is the recurrent laryngeal nerve on the left side, whereas this is the recurrent laryngeal on the right side. And you can see that this is the vagus nerve going up on both sides as well. The relevant anatomy for sympathetics, the sympathetics run underneath the longus coli. So when you're cutting, you don't want your diathermy to be too high. And the 3 ganglion, superior is the level of C2-3, middle at C6, and still at lower down and C6-7. So if you look at this, again, you've got the 3 ganglions, inferior, middle, and superior ganglion, and they're all seen here, along with a recurrent on this side, which you can see, which is going up, and the recurrent on the left side is slightly lower, which is down here. Surgical techniques, both sides are okay, whichever way you're comfortable. Generally, right-handed people operate from right side and left from the left. On the other hand, if you're using a microscope, you need to be careful that you want to be decompressing both sides, because when you use microscope, you generally do your side better. When you're using headlights, then you generally do the opposite side better with loops. So you need to be careful that you are decompressing both sides if required. You identify with C-arm, skin incision is routine. So transverse incision, the levels we're going to be talking about. Many times I use skip incisions when you've got 2, for example, 3-4 I'm doing, and 6-7 I'm doing, I do with 2 separate incision, and they give very good cosmetic results. Skin incision, landmark we already talked about. So C2-3 is the angle of mandible. Hyoid bone is at the level of C3, generally C3-4. This level is what you use. Thyroid cartilage, so you see is a level of 4-5. Cricoid at C6, and the supraclavicular groove is 6-7. If you've got a very long neck, then you need to be careful, and you need to look at the X-ray to confirm that. Blunt and sharp dissection, so you can use both, and you put your finger in once you've separated the fascia that I'm going to show shortly. So you've got the deep cervical fascia, the pretracheal fascia, and the prevertebral fascia. And all these are important to separate when you're going in, because if you don't cut this, then you won't be able to put your retractors in the right place. The placement of retractors are important. And why is that? There are different kinds of retractors. We usually use trimline kind of retractors, in which are the sharp retractors go underneath the muscles on both sides, and blunt go on each side up and down. And you can use distractors. I generally don't use it because it gives rise to interscapular pain, but whatever your preference is fine. Obviously, you resect the disc and you take out the uncovertible spurs by using drill. So the important thing when you're using drill, you need to use either matchstick, a matchstick, or a diamond when you're taking this out, and not go underneath and cause serious problems. We don't use curettes like that anymore when we are taking care of the back part of the osteophytes. Decompression has to be adequate. Again, matchstick and diamond drill is important. You need to decompress both sides equally. You can't be decompressing just one side or making a very narrow trench. It has to be adequate decompression. The grafting and plating, again, the screws should be in a majority of the place now are dynamic. So your screws should be direction always has to be either away from the center, and you're coming in medially. Away because you want to make sure that when the dynamic plate sags down, it doesn't cause any problem. And it's medially because you want to be avoiding the nerve as well as the vertebral artery in case your plate is slightly crooked. So I think that those are important tricks to remember. You should not have a plate this big. The plate should be as small as possible, and your screw should be directed away. So you're going up, not straight. And obviously, when you have got a deformity, you can use a much bigger cage to elevate the whole thing. Another trick regarding deformities, you put screws up and above and below, and then you bring the plate close to the bone itself by the screws, and the whole deformity corrects by that trick as well. The claims are that biomechanically it's stable, facilitates fusion, promotes resorption of osteophytes, widens neural foramen. The proven facts are the graft and graft site complications could be high in inexperienced hands or people who don't have enough of exposure, whereas adjacent level disease could be up to 20%. If you go on exposing level above and below at the same time, you need to be directed just at the level that you'll be working at. Graft is not necessary for a biomechanical stability, and there are multiple studies that have shown that. So short-term results, immediately, brilliant results. Long-term, there's no instability, fusion up to 28 to 100%. With very good stabilization with all kinds of different material that you use. So with simple discectomy, the results are same as your a graft that you use. I generally use graft in every case, but I'm much more comfortable because I can correct the deformity at the same time. And once I decompress, I know that osteophytes won't be coming back there. If it's a single level, you can get away with without any kind of graft. If the disc is soft, you can do a simple discectomy, or maybe anterior foraminotomy or posterior foraminotomy. Large osteophytes, you need to be thinking about fusion, which majority of the cases in our part of the world we see. If the disc height is less than 4 millimeters, you can think about simple discectomy. If it's more, then you may be thinking about ACDF because you don't want the whole thing kinking on top of you. Deformity, if it's kyphotic, then you think about ACDF. If it's lordotic, simple discectomy, you can get away with it. So degenerative cases, ACDF time-honored, gold standard, simple discectomy, as good as ACDF in some people's hands. TDR in some studies have shown promising alternative, yet long-term studies have yet to prove that. Anterior foraminotomy can be performed something like this. You can approach anteriorly, and what you do is you take the anterior lateral 1/3 of the vertebral unit, which is direct nerve decompression. The uncovertebral spurs can be taken out anteriorly. It is special care that you don't want to be disrupting the disc itself. So, this part of the disc laterally and the bone can only be taken. I've done about 10 of these, and all of them are doing well over a long time, but I'm not sure that indication is huge here. It's very short indications. So you go in something like this with a microscope or endoscope and can decompress anteriorly. The anterior cervical foraminotomy, there are 3 different types. And what you need to do is open up the joint like that. And this is the area that you're going to be opening up and decompressing and taking out the disc from front. So generally speaking, it's the transcervical approach is a classical approach that's generally used. And you need to put some kind of a retractor on the vertebral to make sure that there's enough space and your decompression is adequate and you're not harming the vertebral there. So you drill all the way to the canal, lift it up and decompress the root like that. And so this simple procedure like this can result in a decompression as easy as this. Anterior oblique corpectomy can be used where you don't want to be using a graft or a plate. And some of my friends routinely use it. My experience is only a couple of cases. And the results are very good if you're good at it. But again, you have to come lateral to the carotid. And so it's an anterior lateral approach. So you open something like that. So you're coming at an angle. So this is a patient that we're seeing on an anterior lateral approach and the decompression and the dura seen there. So you've got something like this. And once you open up, your results are pretty good in these patients. So you open up and you do a post-op. So if you have got an osteophyte here, you have to come all the way laterally over there. So the results are very, very good. We need to be wary about the approach-related complications, injury to the adjacent tissue, organs. If any time you get an infection in cervical disc, then you think about it, the problem is probably related to esophagus. So the risk has gone down to 1 in 600 now for anterior cervical approaches. And if you do get an infection, be wary that did you hurt the esophagus by any chance? That's why you're getting some kind of infection. Instrument graft related problems can happen if you don't put the screws. You don't think biomechanically about this. You're not worried about the C2 as well as C7, T1 angles. Hematoma you can get very rarely, but if generally I put in a drain for 24 hours and that works very well. Donor place problems, if you do take that, then obviously it can happen, and non-union can happen, which can give rise to neck pain afterwards. Approach related dysphagia, recurrent laryngeal nerve, esophageal injury, very rare nowadays. Vertebral artery injury, I haven't seen, hopefully I'll never see it. Tracheal injury, hematoma and infections are there. Durotomy you can cause, but generally doesn't cause much problems. So complication avoidance, you don't want to be jumping on it. You think of this as your own eye, and what you would drill on your eye, you can only drill like that. So you can even leave this bit of bone if it's floating, and you can have pretty decent results with that. When you're putting in a graft, don't tap on top of the graft. It should be on the side. And usually nowadays, majority of our hammers and the blade that we use to tap in the graft have some kind of a protective element. So please use that and be careful. You don't want to be hitting the cord. So all this is very important for us. And when you're drilling on the side, you need to be wary that where exactly is the joint. How do you find that you've done an adequate decompression? You put some kind of a hook underneath and feel the pedicle. Where you can feel the pedicle, you've done enough decompression. So that is important. Sometimes enough venous ooze can show you that as well, but that is the absolute confirmation. So I'm grateful. Thank you. It was wonderful to give a talk here. Thank you, Vlad. Thank you all, guys. Pleasure to be in this forum.
Salman, thank you. It was great. Very educative and excellent. I would like to start with the spine again, hearing you. Are there any questions from the faculty?
Yes.
Imad?
Imad, yeah, I just want to complete the sessions with the Salman. If he can give a few comments on artificial disc, his indication and patient selection.
Yeah, I think the most important thing is that when artificial disc came in, the initial big vogue, as we know, is to use all those that new things come in. And with time, we realize that everything that we see is not honey. So the indications are now restricted. We know this. So it has to be a soft disc, a young patient, radicular pain. Some of my friends who have shown really bad results from various large trials are because their indications were very, very bad in those patients. So we had myelopathy, we had OPLL, we had osteophytes, we had old patients, we had patients with multiple comorbidities. So I think because of that, artificial disc got a really bad name. And then there was heterotopic ossification, because people were going at multiple levels, leaving a bit of bone underneath as well and not washing enough. So nowadays, we only use artificial disc in those cases where patients are young. They don't have much neck pain, they don't have much deformity, they don't have any osteophytes, and they don't have myelopathy. Some of my friends are still operating with myelopathy and giving good results, but good for them. But I can do better results with what I've been doing all along, a fusion.
And what about cages with the screws, internal screws? Do you replace them as you feel they are better than plating?
Okay, so there are two types of screws that are available along with the cage. One is you've got double screws, whereas one is a single screw. The single screw is really not a good one, because in rotation, you can cause serious problems to it. One of my friends from Europe routinely uses, he says in his hands it's pretty good, but he leaves the collar on for 6 weeks, which we don't in any of our fusion. Then I leave a collar on for 10 days and then off. So with the double screws, yes, it's pretty reasonable. The only problem is that if your screw angle is too steep, then you would cause breakage of the end plate and on both sides. And I've seen many surgeons do that. So I get to see a patient like that with that kind of plate 1 every 2 months. And there's people don't know that angulation has to be correct. And if you're going too steep, you will break the end plate and cause that end plate to be broken, and it comes into your canal and can cause serious problems.
Thanks, Salman. Very good comments.
Most welcome.
Okay. Salman, thank you very much.
Thank you. Pleasure.
Pleasure for us. You've covered the anterior approach. Then there is the oblique approach advocated by Bernard George, which is not much advocated. And then there is the dorsal approach. And this one will be covered by our distinguished speaker, Miguel Arraez. Miguel, please.
Thank you very much. I hope you can see my screen and you can hear me, Vladimir.
Yes, everything's okay.
Thank you. So, well, my talk is in some way in the same, let's say, topic as Salman talked, but I will deal with the posterior approach with some comment in regard to anatomy and selection of approach. I have been, very much demonstrated the possibilities for anterior approaches by Salman Sharif. And regarding posterior approaches, we have laminectomy, and also we have the so-called microlaminoforaminotomy. This is the technique I'm going to deal with over the next maybe 15 minutes. And this is about the keyhole approach, posterolateral approach, removing some inferior part of the lamina or the superior lamina, some superior part of the inferior lamina, and sometimes some limited medial aspect of the joint, trying to identify the involved root and decompress the root that may be, let's say, compressed by lateral disc herniation, in the old terminology called soft disc, or due to foraminal stenosis, due to uncovertebral and or facet joint hypertrophy, as you can see here. But in summary, producing compression of the cervical root. A couple of comments regarding anatomy of the root at the cervical region. This is more for the youngest colleagues in the audience, because unlike the disposition and orientation of the root at the lumbar spine, at the cervical spine, first of all, the mobility of the root is not
Miguel, sorry to interrupt you. Your slide is not moving. Are you moving the slides? Is it frozen on the first slide?
Oh.
And put it in full screen, please.
I am in full screen.
think it
You're
may.
on slide number 3.
Move it one by one, Miguel.
Yes, I'm trying to do that. Can you see? This is
Yes.
first slide.
Yes.
Now,
Yes.
can you see second?
Yes.
Okay. So, well, this is a summary of the approach, the keyhole approach, trying to expose the root, removing some part, as I mentioned before, of the inferior aspect of the superior lamina, superior aspect of the inferior lamina, and sometimes some little part of the medial part of the joint. And these are the two possibilities, the so-called soft disc, and that is a pure herniation, or the phenomenon of foraminal stenosis due to uncovertebral and or facet joint hypertrophy, in any way just producing compression of the root. I was mentioning for the youngest colleagues and regarding anatomy, that is very important, that the mobility of the cervical root is very limited, unlike the mobility of the lumbar root that has a different distribution, different length, and thus can be mobilized more easily. This is where exactly the disc fragment, taking into account the relationship of the disc space and the root, usually is seen. So in the great majority of the cases, we have to look for the disc fragment at this axillary part of the rootlet instead of the upper part of the cervical root. And this is one of the indications. This is a posterolateral fragment compressing the nerve root. This is important to talk about the clinical selection of the patient. Usually we are talking about a young patient with abrupt onset of radiculopathy, very intense and severe compression of the root due, as in this case, to posterolateral herniation. We can see several fragments of soft disc, pure herniated disc, but top on, left and right, we can see the second possibility for surgical indication, that is foraminal stenosis, as you can see here, or you can see in this other view. So best indication to my mind is the so-called sequestered soft disc. This is one of the posterolateral discs producing nerve root compression, and you can see how this fragment in some instances may even penetrate and disrupture the posterior ligament, the posterior common ligament. So you will find the fragment in between the ligament and dura mater. This is one of the cases of foraminal stenosis. It's very important to look at the anatomy, in this case by means of the CT scan, also MRI, but I mean the anatomy of the foramen, because you have to take into account until which extent, if the operation is related to foraminal stenosis, until which extent you should remove the posterior pseudoapophyseal joints, because you have to take into account that if you remove more than one third of the joint, you will probably solve the problem of the root compression, but you won't solve the problem because you will have pain coming from a joint instability. Sorry, because I'm afraid there are some workers in the hospital working in this particular moment of my presentation. So very important contraindication before this noise is coming back. Contraindication, central disc and myelopathy, and also centrolateral disc. So do not be tempted to try to remove this broad-based disc, because you will have problems regarding spinal cord. This is one of the patient. I'm going to show very quickly a video. Important to mention the clinical selection of the involved root, because sometimes you have not one but two images like that. Usually one is provoking compression, but in cases of some hesitation about, you can do at 2 level the decompression and be sure that we have contributed to solve the problem of the patient. The surgical technique includes a very easily, localization of the space. Usually the patient is operated on in prone position. In my former times in sitting position, but a simple needle may just give some idea of the involved level. And this is a quick video. We are working at the left side, and I will move forward. You have to drill, and you have to use only few instruments. You have to use this ranger, this punch. Very frequently, you have to remove some lateral part of the lamina, some small part of the joint. In some cases, you can see the root and you can see the fragment. Trying to palpate with pencil dissector, rotor dissector. You have sucker, you have aspiration, you have also the pencil dissector, you have a small hook, and these are the instruments you need. You have to palpate, to feel and displace toward the operating field the fragment. Many of them, as you can see here, as sometimes we can see at the lumbar region. Okay, I will move forward. And this is the way you have to free the root. See that in that case, you can perfectly differentiate the nerve component from the sensitive component, usually the nerve one in the lower aspect of the root. Okay, this is the opening, very small. This is the root completely decompressed. And I like to call the attention to this issue, that is this fibrous tissue that sometimes is wrapping around the root, and at the very beginning may just provoke some problems, because in that plane you cannot differentiate the root. If so, you have to coagulate, slightly cut and going just to the medial part, because at the medial part you can find more easily the dural plane, and then just dissecting underneath this fibrotic plane you can find the root. This is the surgical technique by means of this small opening that can be done by means of microsurgery or endoscopy. I usually do that by microsurgery. This is the summary of the publication, usually pointing out a very good improvement in the radicular pain. Recurrency, unlike lumbar region, is very seldom seen. Complication can be dural tear, motor radiculopathy, and postoperative dysesthesia. It may happen due to the manipulation of the root. So take care when dealing with the root. Do not manipulate so much, and take care about the possibility of that kind of complication that usually is not seen at the anterior approach. You can see the series with a large number of cases, and just in comparison with the anterior approach, we have to mention that this posterior root, when indicated and done properly, is solving the problem without getting inside the problem of the adjacent degenerative space. That is a problem very much published in the medical literature after anterior approach. Also, you can see in this image how the adjacent space level can be a big problem after fusion, in that case of 2 levels, in one of our patients. And well, it is something that has been described, the possibility of pseudoarthrosis non-union after anterior approach, irrespective of the material you have used. Talking about arthroplasty, seemed at the very beginning to be a very promising technique, but I have to mention that in our team we have been using that less and less due to the late fusion and also the possibility of complication, and among them subsidence. This is not arthroplasty, but this is another material, tantalum, and the possibility of subsidence in osteoporotic spine. And in that case, this is one of my personal cases of pseudoarthrosis after anterior arthroplasty. So if you do the posterior approach, because of the patient has the anatomical and clinical condition for that, you will overcome all the pathology of the hardware related to anterior approaches. Several combinations that are leading to bad results in any way. And I think that posterior discectomy for soft disc has to be taken into account. I had the honor to write this chapter in this book of controversies in neurosurgery, just fighting, if I may say that, against some other possibilities like anterior fusion or anterior artificial disc. And I think this is my last slide, trying to be inside the time frame. Best option in cervical disc disease. Of course, central, lateral, and centrolateral disc have good indication by means of anterior approach, irrespective of the modality. But for lateral and foraminal lateral disc or foraminal stenosis, my conclusion is that we have to take into account the possibility of microlaminophoraminotomy that had obvious consideration from the anatomical point of view. That is the main object of this webinar. Thank you very much for your kind attention.
Okay, Miguel, excellent. Thank you very much. Any questions or remarks? Salman, where are you? Not anymore with us. Anyone?
I have one question here. Imad, for an osteophyte extremely lateral, do you recommend this technique?
Well, actually not. My main indication, I only do this operation in young patients with posterolateral herniated disc, soft disc and sequestered disc. This is the perfect indication. If the disc is content, by the ligament, is also good indication, soft disc. For osteophyte and foraminal stenosis, this is not my favorite operation. You have to do a CT scan and to see until which extent you should decompress by means of facetectomy to free the root. Sometimes too much leading to posterior instability that provoke lateral pain. So this is not my favorite approach. You can do that. I did hundreds of cases with my former chief, Dr. Arjona, who mastered this technique and taught me this technique. But nowadays, I think we have best options.
Thank you.
Yeah, thank you. Miguel,
yes,
early 50s, Paul Busey, very, let's say, fundamental neurosurgeon, did the same surgery as you have shown, and he called it mini-invasive keyhole surgery. That was the first time I have seen these terms, and I really enjoyed that very much. And this is really keyhole, actually.
Okay, good, nice, thank you.
And anyone else? If not, and in case I do not see Baldoncini here with us, Imad, can I ask you to take over the rest of the lectures as a chairman? Unmute, Imad.
Yeah, who is next? If you present the next one, I'll take over, please. Just the name.
Next one, wait a minute. It's Joachim Ertl, but he has written to me that he probably may be late. Joachim, are you here with us? He's not, so then it's Nikolai Pev.
I can do it, but you can also ask Nikolai.
Oh, Joachim is here.
Oh, he is Joachim with us.
Imad, all yours.
Yeah, you can do it as you like.
No, you go ahead. Web schedule, Joachim. You are next, and you are there.
Okay.
And I'm pleased to introduce you. You are the chair at Homburg. You're still there, yeah? I haven't seen you for a while. It's always a pleasure to have you. I know you have. Sorry. And you have, of course, a track record in endoscopic spine surgery other than endoscopy at large. And we are looking for your presentation on endoscopic management of degenerative spine disease. Go ahead, Joachim.
Thank you. Can you hear me?
Yes.
Sounds good. So then we will see if I'm able to show my slides.
Yeah, if you can share the screen. Okay.
Are you with me? Now you see the screen?
Yes, we see the screen.
Thank you very much. It's a big pleasure for me to be part of this WFNS Neuroanatomy Committee webinar. It's, I think, a beautiful webinar with a lot of different aspects. And I will cover endoscopic spinal surgery. I have to disclose that I have a consultant contract with Stort. And I have received honorarium from some other spine companies. This is where I'm from. This is Europe. You see, it's very close to the French border. So 1 hour from Frankfurt, Strasbourg, and Luxembourg. And this is the department where I work at. And this is the university campus. So we switch now to a very different topic. We have a lot of different presentations on spine surgery, but now we switch to spine endoscopy, which has some peculiar aspects, I think, which are related to the technique I want to discuss. So what is the big advantage you have with the endoscope? A very good visual quality, although the resolution is much less than with the microscope, since you have the endoscope and the camera right very close to the target area, you have a very, very detailed image. You can look around the corner, and if you have a smaller approach, because you can reduce the collateral damage in many indications. Ideally, this technique results in a new surgical technique. Well, I think this is ETV in neurosurgery. This is a really big advantage when you can do this endoscopically, but it's rare. For spine, I think transforaminal, this can only be done with a real endoscopic technique. So there is ideal advantages because you have new surgical techniques using the endoscope. In my talk, I will focus on degenerative indications. I think there's another very good indication in thoracic fractures, thoracoscopic approaches, but this is not the topic of this presentation. And in contrast to other endoscopic indications, we have no preformed cavity. So we have to prepare our space to maneuver the instruments and the endoscope. Also, we have very good results with microsurgery, and we need sufficient decompression of neurostructures. So this is, well, a major aspect, which makes it very difficult to see advantages using the endoscope in spine surgery. What can we expect? Well, smaller reduction of muscular trauma, maybe a mini opening, very focused opening with high magnification. Maybe this might result in a decrease of scarring at the spine, at the dura. And then there's a significant patient demand, and we have, well, we want to have less postoperative pain and faster recovery. There's a vivid, very controversial discussion, particularly between microscopic versus endoscopic. And then if you think about endoscopic, then you discuss tube-based versus full endoscopic techniques. And then there's another discussion, transforaminal versus interlaminar. And I presented this at the World Spinal Column Society virtual world meeting in late August, so 1 month ago, about transforaminal, and I will not go till today. I will just present to you the endoscopic options. What is the status of evidence in 2020? We have shown that there is no longer a higher recurrence rate and a higher complication rate when we use the endoscope than with the microsurgery. So it's not that we have evidence that it's better, the endoscope, it's just that we have the same recurrence rate and the same complication rate we can reach with the endoscope compared with the microscope. However, immediate postoperative pain, particularly if you use the very small tube-based procedures or the shear endoscopic procedures, is reduced. and you have a faster recovery. Of course, you have then with a very small skin incision, a superior cosmetic results. However, there's no evidence for superior long-term results in the year 2020. So what is the ideas and the approaches? What is possible? You see here all different endoscopic techniques. As I said, tube-based endoscopic assistance and then percutaneous shear full endoscopic. I will not go too much into detail here, but rather, for me, it's important that we can divide the techniques in an interlaminar approach and a transforaminal approach. So a far lateral, posterolateral approach in the extraforaminal space and the interforaminal space, and then an interlaminar approach where we can basically deal with the whole spinal canal. These are the different indications: a standard medial lateral disc prolapse, a significant lumbar canal stenosis, or as you see here, an extraforaminal. When we look at the status of evidence, we have to evaluate only the most recent papers, let's say the last maybe studies within the last 8 to 10 years, because there's a dramatic improvement in technology and surgical techniques in the recent years. You see here, for example, a definition system. You see that the information you gain just from the image is much, much better with the HD camera system. And now we have 4K, which is even better. So I want to discuss the tube-based system, the transmuscular approach. So this surgical technique is very, very similar to the open microsurgical technique. The only difference is that we don't go at the spinous process down. No, we go a transmuscular approach right to the target area. So we directly approach the target. So we reduce the muscle trauma. We do not detach the muscles. We don't retract the muscles that much. And we just focus on the decompression of the neurostructures. What is important? The difference between the tube-based system and the open microsurgical technique is, the main difference is that you really have to plan the procedure from the beginning. You need an X-ray for perfect localization of the skin incision, and then you dissect the fascia with the skin incision, and you use the dilators to introduce the endoscope. Parts of the procedures can also be done with a microscope with the tube-based system, but it depends on the diameter of the tube, whether you have to use the microscope, or you can have to use the endoscope, or you can still use the microscope. Here's an example. This is from one of our systems, the EasyGo system, that you can use almost all diameter for manipulation when you have introduced the endoscope. And you can think that because you don't need the corridor for the microscope, you can reduce the diameter of the end of the work tube significantly when you use the endoscope. Typical example here, you see a sequester disc prolapse, at 4-5 caudally migrated, and this is a typical situation, what it looks like. I will forward a little bit. You see in the upper part of the screen is the midline, and the lower part of the screen is lateral. And just to get the idea what the magnification is like, this is a 2 millimeter Carrison punch, and the suction device is 2.3 millimeters in diameter. So you expose here the thecal sac, the dura. Then we retract, basically like a microsurgical procedure. The only difference is that it's really small. I mean, if you use a 4 millimeter Carrison punch, you would not be able to bring it in. You see here now the disc prolapse. Then you just manipulate and mobilize, and ideally, of course, a huge sequester is coming out. This can be done with a skin incision like 1 centimeter. So the cosmetic result is very good. In contrast to this interlaminar approach, what we use for intraforaminal and extraforaminal disc prolapses, posterolateral approach. You see here the technique we use. It's an example here with the spine tip technique, but there are many different other brands available, products available, which I think do all the same job and will provide the same results. So here, this is the system, 8 centimeters in length. You see a 15-degree optical lens, and you see here irrigation and suction channel, an optical lens channel, and then a working channel with about 3 millimeter diameter. The difference is that this procedure is completely done under water, so continuous irrigation. What is the technique like? So we use the inside-out technique. We enter the disc space with a needle, come from lateral, calculate the distance, and so usually it's 12 centimeters lateral. Then we approach the disc space right at the frame, and we do discography that we are inside, and then we change to the working channel and introduce the working channel, and then we retract that we are right at the intraforaminal space. You see, this is of course an ideal example. You just go in, basically everything has been mobilized because you went through the sequester, and then this can be done in 10 minutes or less. Skin incision here is even smaller, like 6 to 7 millimeters. A very good cosmetic results. And these patients, indeed, they have very, very, very minimum postoperative pain. So now I come to the status of evidence. What is evidence? What we can look from the randomized studies, what we can gain from the randomized studies. Is the endoscopy superior to microscopy? And you see that the problem is that there has been various endoscopic techniques included, various indications, and various outcome criteria. So when we go through all the data right now, the application is possible in a wide range of indications in degenerative spine disease. Most of the randomized studies are lumbar. We also have very good results in cervical applications, but there are very few randomized studies for the cervical. And in all these recent randomized studies, we have evidence that the complication rate is no longer higher than with microsurgery. We have evidence that the reduced muscle trauma by use of sheath systems or pure endoscopic systems gives better result. We have less muscle pain, less muscle scarring, and we have, because of the small skin incision, superior cosmetic results. These two things that we have evidence for from the randomized studies. When we look at the level of evidence for long-term results, for revision rate and success rate, then we have to be honest that although there are some randomized studies available, we have very, very low evidence, very weak evidence that we have better results with the endoscopic system. So on the long-term revision rate, success rate, we have to be honest that microsurgery and endoscopy provide the same results. I have a couple of different indications now. When we look at lumbar canal stenosis, for example, we would come as an example from an interlaminar approach and use this with a tube-based system. So this is the contralateral side. We do the decompression with a diamond burr and a sheet-based endoscopic system. So this would be in our hands. This is one of the most frequent indications we have now. This would be a classic indication for an endoscopic tube-based interlaminar approach. So this looks like this in the post-op CAT scan. Classic indication for an transfemoral shear endoscopic approaches. This case example here you see it's an L4, L5 left-sided intrafemoral disc prolapse. And then you would calculate the approach like this. This is usually, in this case, was 12 centimeters lateral. Use the posterolateral approach. We go into the disc space and then we retract. This is the technique. Puncture of the disc space, discography, and then Seldinger technique, guidance of the endoscopic system. And then you go in and retract and mobilize. And this is a typical case when we have a huge sequester like this. This was done in 6 minutes, 49 seconds. However, we only use this technique in soft disc prolapses, intraforaminal or extraforaminal, everything which is in the spinal canal, and particularly we have a lot of old patients in aging population, and you have to drill a lot and you have to mobilize the tissue. Then I think it's better to use an interlaminar approach. So to conclude, we have the same outcome right now when we use the endoscope as we have with the microscopic techniques. We have standard interlaminar techniques, which at least we prefer to use a tube-based system. But we have a new technique, a transforaminal technique, particularly for intraforaminal and extraforaminal soft disc prolapses, which gives very nice results. At both endoscopic techniques, we have less muscular damage and superior cosmetic results in comparison with the microscope. So I think particularly for the right indication, endoscopy will play a significant role in the treatment of degenerative spine disease in the future. I thank you for your attention and my whole team for collecting these data. Thank you very much.
Thank you very much, Joachim. It's a wonderful presentation. I'm sure cost effectiveness will become a very important component of this procedure, or the decrease of the length of stay. I can imagine these cases you might send them same day procedure or outpatient procedure. I have one question. What is the percentage of cases you revert to microsurgery from endoscopy in your practice?
Yeah, good question. It's actually very low, surprisingly low. In the beginning, in the learning curve with the tube-based system, the learning curve, we have published this recently, I think, in World Neurosurgery, is about, well, depending on, of course, on your personal experience, between 15 to 30 cases, so very few. So in these first, let's say 20, 30 cases, you have some revisions, some converting to microsurgery. Later on, it's very rare. I cannot remember when the last time when I switched from endo to micro. This is different for the transforaminal system. For the transforaminal system, the learning curve is not that steep. It takes a long time to have a good result. So I think you have to do minimum 60, better 100 cases. And still, we sometimes switch from endo to micro, particularly if we have the impression that we did not take out and decompress the nerve roots in a sufficient way. Then we actually do not hesitate to switch to an open procedure. But I have no clear data how often that is. Let's say 85%, not more than that, but not very rare.
And since we have young trainees attending this webinar, do you advise them, whoever wants to proceed doing endoscopy, to build up the learning curve in microsurgery?
I think it's better. I think it's better that you know, either you have to do anatomy lab or you have to do microsurgery, because the anatomy is not very obvious when you have these mini openings. This is the difficult thing in learning the endoscopic techniques. You have to exactly know where you are, otherwise it's a disaster. So I think either you do a lot of anatomy study, anatomy practice, or I think you need to do some microsurgical open cases before.
Thank you. From the panels, any questions?
I just want to comment on something. Hi, Joachim. Good to see you.
Hi.
Do you think at some point you'll be doing intradural procedures with this endoscopic technique?
Well, some do in intradural procedures with this technique. I don't know. So rather, when I do like, cavernoma, epipneumoma, so really intramedullary tumors, I want to have all the skills available. So I tend to do a rather large opening. I don't want to have a small opening. I rather do, if you do laminotomy, I rather add a segment which I might not need. than being too small in the approach. So I personally, I don't think that this is the focus for an endoscopic minimally invasive procedure, but some do, and some present nice data. So I think it's possible, but if you want to have the best results, you know, to be sure that you can have all the bimanual skills to get the best result for the patient, I'm not sure whether we really should proceed with this. Maybe some selected cases, very small lesion, like a neuroanoma or something, you know that you just open up the dura and it pops up, then of course it's no problem.
Great. If no further questions, thank you, Joachim. We'll move to
It's been a pleasure.
It's a pleasure to have you. To Nikolai Piv, he is going to speak about the merits of the lateral lumbar decompression Wilsey approach.
Thank you, Imad.
Nikolai is a close friend, a brother, and he has been with the group for several years, or joined the anatomy group in different occasions, and he is practicing under the British flag.
Thank you so much, Imad. It's a pleasure being with you, an honor. And I am trying to share my screen now. Yes, so can you see the screen now?
Yes.
Okay,
wonderful.
So
yes.
Perfect. So I'm going to present to you today Wilsey approach and what we can do with Wilsey approach and how can we push the limits of that approach. It's one of my favorite approaches and I use it a lot. I have to disclose nothing, but just that this Wilsey approach actually is, in my hands, a working horse for my minimal invasive surgeries. So before I start, I just want to introduce to you or just remind you the concept of surgery. What is surgery? So basically, when we do surgery, we have to create approach to the lesion that is normally inside the body. So we go through to healthy tissues. We destroy healthy tissues. Despite the surgical techniques we use, inevitably we leave some footsteps. And this is a major problem with any surgery. We try to minimize these footsteps, and hence we are developing different surgeries, different surgical techniques, and hence minimal invasive surgery came to play. So what is minimal invasive surgery? That's a procedure that you will do your surgery without leaving so much footsteps. That's the main advantage of the minimal invasive surgery, and you still will be possible to reach the end goal. How are we doing that with minimal invasive surgery? We are doing this by avoiding destroying the normal tissues, by splitting muscles, by not detaching muscles from the tendons, and using limited width of the surgical corridor, using known anatomical planes. My objective at the end of this talk is to show you that you eventually can do different things with this minimalistic approach, and what is not possible in the beginning, with time it becomes possible. Another objective is to show you that you don't need to see the whole picture. So you see here, I'm showing you part of that picture, and you still be possible to see who is on that picture by me showing you just a small piece of it. This is something like minimal invasive surgery, and this is how, after some training, you will start recognizing what is on the whole picture only by seeing a small piece of it. This was Vlad. If you did not recognize it, he is one of our hosts today. So necessary anatomy. We are all, as neurosurgeons, we are all trained with doing classic lumbar discs, open procedure. You're all familiar with this procedure. You're all familiar with this anatomy and with this approach. This is a well-known interlaminar approach, and you do this bony work here in order to remove the disc, and you tailor your bony work based on the where the herniated disc is. On the left-hand side of the screen, you can see that about 30% of the discs you will normally find at the level of the disc. and then some of them will be caudally migrated, about half of the discs, and small percentage will be up, and very small percentage will be far lateral. This is what we expose as bony anatomy when we do the majority of the discs. Midline, classic standard midline approach interlaminar procedure. This is what happens when we do laminectomy. We try to expose a little bit more, or if you have to do fusion, we have to expose even more. This is the classic open approach that everybody or majority of us are familiar with. When in the rare occasions when we have this far lateral disc, we have to go on the other side of the facet, and this is the anatomy that you see when you do far lateral discs. You see on the right-hand side, there is a far lateral disc, and usually we approach this with exposure that will give you the beginning of the TP up and down, transverse process, and then outside of the lamina, and then lateral side of the facet. This is the anatomy that you normally will see when you're performing your lateral discs. And the majority of us are still familiar with that, although the lateral discs are not very, very often. As you can see here on the left-hand side of the screen, about 7% of the discs are lateral. You have to be aware that also this approach that you will develop for lateral disc, which is the Wilsey approach, is not straightforward, but there is it comes oblique to the structures. So you have that oblique view of the anatomical structures of the level that you're approaching. You can see that on the right-hand side of the screen. So let's see now what is the classical approach, what we do when we do a classic open surgery. We first open the skin, then we open the fascia, we detach all the muscles, and we expose all the bony anatomy that we need. We can tailor, obviously, this approach to based on the levels that we have to approach. This is obviously quite extensive approach. Usually we open 2, 3, 4 levels at a time, unless there is an extensive deformity surgery that we need to do. My point is that by doing this classical open approach, we have to detach the muscles both sides. We have to go all the way, surpassing the facet, and we have to even sometimes detach the muscles from the transverse process. And this is quite big and quite extensive approach, and quite a lot of muscles being damaged like that. And this has consequences for your patient. The beauty of the Wilsey approach that I'm talking about today is that, unlike that classic open approach, you don't need to detach muscles. You can develop that approach in between the multifidus and longissimus muscles, where there is a natural plant that will give away on your finger. I will show you that later. And through that small approach, you can achieve a lot, and you can do a lot of things, which I will demonstrate a bit later. So, going back to different surgeries, obviously the concept of minimal invasive surgery is, as we said, leaving less footprints. So this will be the end point of the majority of the spinal surgeries. We normally do decompression, we do fusion, we do fixations. And for me, it is no-brainer which way I would like to go if that's my back. If something can be achieved via a small approach that is on the left-hand side, obviously I will use that if that's my back, but I will not go for this big opening which is shown on the right-hand side. And same thing here. So Wilsey approach, how we do it. First thing is, of course, planning. You have to sit in front of your MRI scan, and you have to do the necessary measurements. As I said, Wilsey approach is based on that plane, which is usually a fatty plane that you see on the MRI scan picture. And that gives you very good plane that you will not need to cut any muscles, and you're straight to the bony structures that you need to approach. So normally before I start, I do the necessary planning on my MRI scan. As you can see here, I have measured the offset from the midline. Normally for adults in my practice, that will be between 40-45 millimeters. And then you can measure also the depth to your anatomical bony structures. And like that, you can make sure that you have the instruments with necessary length. Also, I'm using spinal needles. I will put the spinal needles roughly to mark my upper and lower margin of my skin incision. And then I will finally end up drawing this lines here. And this is the line where my Wilsey plane stands. And then the needle here and the needle here will mark my upper and lower margin, as you can see here on the lateral x-rays. And this is where I will place my, my skin incision. After the skin incision, you have to just cut the fascia, and then everything else is giving up on your finger like that. But you have to be sure where you put your finger. You have to put your finger on the right spot. And here on that picture, I am demonstrating where exactly and what you have to feel with the tip of your finger. It's very important that you feel two objects. One is the facet and the other one is the tip of the transverse process. Very common mistake when you start doing this approach is feeling the tip of the transverse process and thinking that you are feeling the facet. And then I have seen this. Somebody that I was working with ended up being in the retroperitoneal space and had a major bleed. You would not be pleased with yourself if you do that. So make sure that you feel the TP and that you feel the facet before you start cutting further. So after you develop your approach, which normally takes a few minutes, for cutting your skin and the fascia and then developing the plane with your muscle, it's time to put your retractor. Any retractor can be used for that purpose, even if you don't have these fancy MIS retractors. With a little bit of thinking out of the box, you can apply any retractor. And having on mind the principles of the minimal invasive surgery, you can do your approach with anything that you have on disposal. Even now, I use this McCulloch retractor for the majority of my surgeries. And then when I apply my retractor, my approach looks like that. As you can see here, you don't discriminate any of the anatomical objects, but that is not a disaster. If you have done your proper planning, you know that you're on the right spot, and with a little bit of developing of your plane with the cautery, with the monopolar, you will start getting your anatomical landmarks, and you will be okay to proceed further. Of course, if you're not sure, X-ray should be helpful. That is what you see, but that is what you should imagine. You should know if you're this was where your needles were when you were planning your approach, and that is what you have to imagine when you are when you have opened your approach. Here you can see key wires. Sometimes I put my key wires in case I have to do the fusion surgery, but that is not mandatory. So again, this is the anatomy that you have to imagine that should be at the bottom of your approach. You have to know where is your transverse process, where is your facet, and where is your lamina. So again, this is at the bottom of your approach. This is what you imagine, and this is what you see in the real life. But again, what I told you, with a little bit of work of the cautery, the anatomical objects are shaping in front of you. The bone is your friend. So as soon as you stay close to bone and develop your approach with the mono or with bipolar, you start seeing your inferior transverse process, your superior transverse process, and your facet joint with superior articulating and inferior articulating, and with your lamina. Again, this is what you see in reality, but this is what you imagine. That is what is in your brain. Next step of the procedure after you have localized your structures, your anatomical structures, is some sort of bony decompression. You can remove, if you remove completely the facet, which is happening with many procedures that are performed with that Wilsey approach. As you can see, you have access to the space where you normally expect to be your traversing nerve root, your exiting nerve root. You can see that over the top, if you do a lot of enough decompression, you will have access to the contralateral exiting and even the contralateral traversing nerve root. This is what you see in reality, however, and this is what you imagine. You know where your nerves, and knowing the anatomical landmarks, knowing where your bones, knowing where is your inferior and superior pedicle, you know where to go. Again, this is what you see, this is what you imagine when you're performing your surgeries, and X-ray sometimes is very helpful in case you feel you're lost and in case you're not sure with your anatomical landmarks. Discectomy is usually the next step, or might be even the first step if you're performing just a far lateral disc with this approach. Very easy done because as you open and you slide down to the inferior pedicle, you're right on the disc and you can easily do the discectomy that is needed. After you perform your discectomy, then you may stop in case you're aiming only simple discectomy, but you can introduce different cage or interbody devices, which will help you to achieve the fusion that you're potentially aiming. Again, that is what you see, that is what you imagine. This is where your nerve roots will be. In the majority of the cases when I'm doing my surgeries, I don't see my exiting and traversing nerve roots until I complete my discectomy or introduce my interbody devices. And only after that, I may develop my anatomy further and I start seeing my the neural elements, the exiting and the traversing nerve roots. Following this surgery, following the introducing of the interbody devices, then you may continue further and you can enlarge the bony decompression. And as I said earlier, you can gain access to the contralateral, traversing and exiting nerve roots. This is a model that I was using to create that presentation, and you can see here when you do complete facetectomy, and if you enlarge the facetectomy with removal of the lamina, you can see the exiting nerve root, you can see the traversing nerve root, and you can see the contralateral, the central dura and the contralateral roots as well. So this could be an endpoint of your surgery. You can see here after such a decompression, I was possible to see to introduce a cage, which is interbody device that will help the fusion. I was possible to decompress very nicely the exiting nerve root. You can see here the traversing nerve root is decompressed, and I also was possible to see the central dura and contralateral structures. A few cases that I have done with this approach, you can see here high-grade spondy, which had to be fused. And you can see with minimal invasive Wilsey approach, I was possible to introduce L5 through transdiscal to S1 transdiscal to L5 screws. And I was possible to do a minimal invasive TLIF procedure at L4, L5 with the same approach. Another case, 87-year-old, which was operated with minimal invasive surgery. 87 is a bit it's a bit scary for many surgeons, but in case you have good health of the patient, because of the minimal invasive, you are possible to achieve good results and faster recovery, and the age will not stop you as much as if you're doing the extensive open surgeries. Revision surgeries also possible with a minimal invasive keyhole Wilson. You can see that this was a case that was done before me from somebody else. Only fixation with pedicle screws without interbody device. Unfortunately, the screws are pulling out. I managed to revise that with Wilson approach, and you can see where was that's the post-operative result. One of my screws, which I unfortunately put too medially, was possible to revise through the same opening with repositioning of the screw. This technique and proper positioning of the Jamshidi needles is giving me the big accuracy, and I'm possible to do revision surgeries also with that. You can see this was a patient with a young patient, 28-year-old patient with BMI 51. I was possible also to do two-level T-lift surgery with Wilson approach. That was very helpful, and it is very helpful with this very big patients, because otherwise the classic approach will need quite significant opening with chance for complications. You can see this case, there was a tumor that was eroding in the vertebral body. This was also done with Wilson approach with bilateral Wilson, one side only screws, the other side decompression and removal of the tumor. So Wilson approach is giving you a chance to do far lateral disc, and probably you have to start with that if you would like to start with this approach, and later you can progress with a bit more complicated surgery like minimal invasive transforaminal interbody fusion. You can achieve central decompression. You can achieve revision surgeries. High BMI, elderly patients, spinal tumors will not stop you to use this approach when you have a bit more experience. Why complicated? Why complicating? Why not using still the old approaches? Because minimal invasive surgery will give you a chance to operate patient groups that you would not operate before. Patients are asking for it, and this is a cost-effective procedure. When you gain experience, you will soon realize that will reduce your need for instrumentation and fusion, and you will have less complications. Thank you so much.
Thank you, Nikolai, for this wonderful overview of this technique. I liked it. And I'll open the venue for questions by the panelists.
Thanks, Nikolai. That was a great talk. What if you get the CSF leak?
So because the opening is actually quite small, I do see small dural tears. Well, I wouldn't say regularly, but I would say often. Especially if, let's say, I do somebody who is operated, let's say, if I have to do a T-lift, usually in my practice, this is somebody who was operated 2-3 times by somebody else. And then finally they give up and they send it to somebody else, and I don't say no. So because of the scar tissues that you will normally see, and because of the instruments, which are pretty big for this small opening, I do see sometimes small dural tears. Quite often I will just leave them and I don't have problems, because There is no big cavity that you will have pseudomeningeal cell formation or big CSF leaks, and the muscles are going back together quite well. And if you stitch the fascia and then you stitch well the skin, you normally don't have problems.
Okay, thanks.
How extensive you go with the discectomy to guarantee space for the cage? Do you do very aggressive removal of the disc, or you just initiate some of the space and scratch a little bit of the end plate?
So I would advise, if you're trying to achieve interbody fusion only with interbody cage, you have to go pretty aggressive. You have to make sure that you achieve the same clearance of the disc that you would normally see when you do ACDF. And this is not always the case. I've done an experiment. I'm sorry I did not put that video here, but I have a video when I was scraping the disc for 10-15 minutes. And then I decided, let me now see what I have achieved with the endoscope. So I put the endoscope in, and I was surprised that actually the disc is not clean at all. So really, in case you need to achieve good fusion, you have to push for good clearance of the disc. You have to remove the end plates properly. You have to clean the end plates properly. Many critics of the minimal invasive approaches are saying that you have inferior fusion rates. That is not because of the type of surgery, that's because of the surgeon. You normally don't clean the disc, and that's why you don't have fusion. That's the majority of the cases, in my opinion.
Any other questions by the panels? It seems Vladimir, you are with us. Is Kasadi is giving his presentation, or will be scheduled?
Rescheduled. Kasadi is rescheduled. I discussed this with him, and he agreed to reschedule for the next one.
Well, then I think, Vladimir, if you can reconvene the sessions and conclude, please. It's the last topic.
Imad?
No, you today is yours.
Thank you. Well, it was a great pleasure and great honor to be here with you, and I really was glad to see all of you, and I also was glad to see the number of participants, which is not negligible. All the lectures were excellent. It was really top of neurosurgery, and I have learned a lot myself. So I believe that the residents did learn even more. The only thing I still do not understand, Ramesh, are those fistulas. I'm still fighting with angiographies, and I'm still having troubles with that. Yeah. But it's my own problem, not yours. So thank you very much. I hope that you will all join us for the 6th seminar, which will be in a month's time. And I believe that you will enjoy it. And I believe that Imad will be again that successful with choice of lecturers and with choice of program. Thank you very much, and enjoy the rest of the week.
Thanks, Vladimir. Thanks, everybody.
Thank you.
Thank you.
Good night.
Thank you.
Okay, bye-bye. Thank you.
Bye-bye.
This time was very informative. I'm ready for next time.
All right. Thanks.
All right. Thank you, Takashi.
Okay, cheers. Thank you. Bye-bye.
Thank you.
Bye-bye.
Bye.
Bye. Good
Bye,
night.
Igor. Pablo, you are great.
Nikolai, all of you. Bye-bye.
Bye.
Bye.